Good morning, everyone, and you're welcome to today's webinar, which is hosted by the EACCR, which is the East African Consortium for Clinical Research, ALERRT, and the Global Health Network. My name is Dr. Bernard Chikaire, and I'll be the chair. And I'll be co-chairing with Professor Julian Caesar from Oxford. Today's webinar is about research in global health emergencies. And we are hosting it as the EACCR in conjunction with ALERRT and the Global Health Network, as I've already said. The EACCR is the East African Consortium for Clinical Research, and the ALERRT stands for African Coalition for Epidemic Research, Response and Training. And these two are networks that are funded by the EDCTP, which is EU. And their aim is really to capacity build for research, one during epidemics and the other generally research in the Eastern African region. And so you're very, very welcome. My co-chair, Julian, is a doctor, PhD, and is a special advisor in ethics and human rights to the British Medical Association and an ethics advisor to Medicine Sans Frontiers and Save the Children. His particular interest lies in health and human rights, medical ethics in times of conflict, humanitarian ethics, public health ethics, and mental capacity. He's the author of several books, including his Medicines Still Good for Us, and writes widely on issues of ethics and health. He's also a co-author of Medical Ethics Today, which is the BMA's handbook on medical ethics and medical law and assessment of mental health capacity. And he's a regular contributor to the BMJ and the Journal of Medical Ethics. He sits on the BMJ's Ethics Committee and was until recently a member of the Nuffield Council of Bioethics working group on ethics aspects of research in global health emergencies. He actually lectures widely, both nationally in the UK and internationally on the number of topics which are ethics related. Julian, you're very welcome.
Thank you, Bernard.
So as you can see, today's program is quite full. So we've broken it into two sessions. We'll have a session in the morning and a session in the afternoon. And the morning session will have a break at about 11:10. I'll welcome Julian to take us through the housekeeping rules before we invite the first speaker. Thank you.
Thank you very much, Bernard. Can I just say, first of all, it's an absolute pleasure to be here this morning. It looks like we're going to have a fascinating workshop. So thank you all for attending. Obviously, we are doing this online via Zoom. So who knows what may befall us technologically as we proceed during the day, but we have a fantastic team supporting us technologically. So I'm very much looking forward to this morning. Just a few questions now, a few issues around housekeeping. Please be aware that the workshop is being recorded and it will be shared on the Global Health Network platform. As participants, your videos and microphones have been disabled. That's essential really to enable the platform to function. If you want to introduce yourself or post comments and questions, please do use the question and answer box, which you will find at the bottom of your screens. Critically as well, and you'll find some of this information in the chat bar as well. To be eligible for a certificate of attendance, you must attend at least 80% of the workshop each day and complete the workshop evaluation, which will be shared again in the chat box and sent to you via email. And your certificate will automatically be emailed to you once you have met those requirements, and you'll get it within a month of the workshop. So just finally, again, welcome everybody, and I'll pass the chair now back to Bernard to introduce our first speaker. Bernard, you're muted.
Thanks, Julian, for that, those housekeeping rules. I think the biggest is to remember that the certificate will come your way in email about a month later. And we have a Q&A function on the bottom of your panel. If you look, you'll see the Q&A function. If you have any questions, please post them in the Q&A function, and we will be able to see them and respond to them accordingly. So we're going to welcome our first speaker, who is Professor Julius Lutwama, who is the Deputy Director of Uganda Virus Research Institute and an Assistant Director of Research with the Ministry of Health in Uganda. He heads the Department of Arbovirology, Emerging and Re-emerging Viral Infectious Diseases at UVRI in Entebbe, and heads the Uganda Viral Hemorrhagic Fever Diagnostic Laboratories in Uganda. He coordinates the zoonotic diseases surveillance and influenza surveillance programs and has over 35 years of research experience. He has worked on many viral diseases, including Ebola, Marburg, influenza, yellow fever, dengue, chikungunya, onyongnyong, Rift Valley, Crimean Congo, and many others. I don't know if there's any that he has not looked at. His research interest is in the field and laboratory research and epidemic aid investigations for vector-borne viral infections and other emerging viral infections, looking at disease etiologies, ecology, surveillance, prevention, and control. He's an associate professor of medical microbiology at the College of Health Sciences in Makerere University, and has received several grants from international funding bodies, with over 120 publications in different journals, several book chapters, and several presentations. Julius is very well placed to speak to us about the overview of research in epidemics, because he has been doing this for the past 35 years. Please, let's welcome Julius. Thank you.
Thank you very much, Chair, Dr. Barnett. My presentation, as already indicated, is an overview of research in epidemics, critical areas for research, and the necessary preparations. As indicated in the title, it is an overview. So as an overview, I'll be more and more or less skimming through the topics and not really presenting critical examples. I will speak about what an epidemic is, conditions in an epidemic, what are the ideal situations for research in an epidemic, is research necessary in outbreak situations, is research during outbreaks acceptable, what are the critical areas for research during outbreaks, and of course, what do we need to prepare for during, if we are going to do research during outbreaks. So what is an epidemic? Of course, you will see me interchangeably using epidemic and outbreaks. An epidemic is a rapid spread of disease to a large number of people in a given population within a short period of time. So this may be due to changes in the ecology of the host population, alternatively to be increase in the density of the vector species. For example, if it is malaria and the Anopheles mosquitoes suddenly become too many and they start spreading a lot of malaria, that may be referred to as an epidemic or an outbreak, so long as it surpasses the normal situation. It may be a genetic change in the pathogen. For example, it may be changes in virulence of the pathogen and it becomes more virulent, or it may be due to the resistance of the people in the area, which would have probably changed, or the resistance of the pathogen that would have changed and becomes again more virulent. It may be an introduction of an emerging pathogen to a host population. So all of these may lead to an epidemic outbreak or an outbreak. It may be increased occurrence or episodes of a disease in a population. Then there is epidemic versus a pandemic. Epidemic is within a localized area, while a pandemic spreads over a big area, most often surpassing the borders of one country into another country, all from one continent to another continent, just like we are seeing the COVID outbreak at the moment. So conditions in an epidemic actually refers to a disease situation that is out of control. So when you say there is an epidemic, when there is an outbreak, it is a disease situation that is out of control. You have sick people, and they may be, there might be multiple deaths in the population. There is poor or broken down or overwhelmed health systems, in which case they cannot cope with the situation as it is. There may be a lack of or shortage of treatment, such that some people are not being treated, and because of that, the epidemic is going on. The population is confused, disoriented, apprehensive, or even aggressive. Just on the right-hand side, this is what was happening in one of the towns in the DRC during the recent Ebola outbreak. The health workers had to move out and walk through the town because the town was being aggressive to them. So that is why you see policemen moving with the health workers who are saying, we are working for you, yet you want to kill us. So the population, these are some of the conditions which take place in an epidemic. There may be breakdown in governance structures leading to disorder, and the communities may mistrust those who are assisting them. So in these kind of situations, are these really ideal situations for research? Is research in outbreak really necessary? Or is research in outbreaks acceptable? So those are going to be our next topics. So what is the ideal situation for research in an epidemic? Actually, there is no ideal situation or non-ideal situations for research. So there is no ideal situation. What is important is that there are questions which need to be answered. And if there are questions which need to be answered, then these questions should be answered during the conditions which are available. So research may be conducted in all situations. Though outbreak situations are challenging, situations to conduct research are necessary. Research may cause direct harm or inadvertently add to existing injustice and exploitation of the research population. But there are also risks in not conducting research. For example, the risk of providing inadequate, ineffective, or even harmful care. So we need to carry out research to make sure that what is prevailing is not more of a risk than actually doing the research to end these harmful conditions. It may be the only opportunity. For example, during an Ebola outbreak, because, or even during this COVID outbreak, as we see it now, this may be the only opportunity we have to carry out research, to see how best, to see what are the necessary conditions, which are the treatments which we need to provide, which vaccines need to be produced to be able to contain the situation. So that is why research has to be conducted even when the situations are not really ideal. So is research necessary in outbreak situations? Yes, research during outbreaks is an opportunity to collect information, important information, that can contribute to improving outbreak control measures, such as conducting clinical or vaccine trials. It may be the condition for us to get better evidence about what helps or does not help during an outbreak in order to improve the response to the health emergency or the outbreak as it may be. Research conducted during the outbreak situation may play a crucial role in obtaining this evidence and helps support the immediate response as well as learning for response to future outbreaks. So what the research we do during the outbreak is going to help us to know what to do next during any other outbreak that may come. So research is important because it is an evidence-based approach. Is research during outbreaks acceptable? According to the International Ethical Guidance for Biomedical Research involving human subjects, it is acceptable. So to be ethically acceptable, research must have a realistic prospect of generating information that constitutes an adequate basis for learning. So it has to constitute an adequate basis for learning. In the case of an emerging infectious outbreak, ethical, acceptable research must provide the information needed to put stakeholders in a better position to understand and make decisions regarding the use of new interventions and to address similar outbreaks in the future. So therefore, research during outbreaks is acceptable. If it is acceptable, what are the critical areas for research during an outbreak or during an epidemic? Well, highest priority is research that can quickly answer specific critical questions in a way that impact response very quickly. Another high priority area is research that answers critical questions that come up repeatedly in different responses, so that response is made more effective in the future. So it might be that there may be many outbreaks, there may be epidemics, and these epidemics are occurring often. Yet, if we carry out research, we may be able to get ways of making sure there is less and less of these conditions happening. So we need to carry out this research to get to answer those critical questions. Why is this reoccurring? How can we best stop these outbreaks from taking place? Researchers in emergencies need to pose clear questions and design a methodology that answers those questions with the minimum of resources and can produce evidence and advice to influence action in real time. So how do we prepare for research during outbreaks? When should we prepare for research during outbreaks? As our first question. Preparedness and response to outbreaks is an ongoing activity. Since this is an ongoing activity, so too should preparations for research during outbreaks. So preparing for research during outbreaks should be an ongoing activity because it is part of preparedness and response to an epidemic. In preparedness plans for outbreaks, we normally identify the threats, the risks, and gaps. And we also should identify research questions that can be addressed as a component activity of the preparedness effort. So as we are looking at the preparedness plan, for example, we had preparedness plans for influenza outbreaks, which was being suspected as the next pandemic. So in these preparedness plans, we were identifying threats and risks and gaps. And of course, it is important that we also identify research questions that need to be addressed. So identifying the recognizable gaps during an outbreak is also an urgently needed process. So even during an outbreak, we need to urgently look at the gaps, recognize the gaps, and pose questions. This process should generate research questions for high priority study. We need to carry out a systematic analysis of gaps encountered after an outbreak. This will probably identify research questions that need to be addressed in another outbreak. So as you see, when you are preparing for an outbreak, you look at research gaps, you look at what questions need to be answered. During an outbreak, again, you look at what are the gaps, what are the questions that need to be answered. Then after the outbreak, again, it is important, after the epidemic, it is important to look at the gaps. What should we have done better to stop this pandemic, stop this epidemic, to stop this outbreak from causing a lot of misery, from causing a lot of harm to the population? So the knowledge that is gathered through well-designed, effectively executed research in anticipation of, or in the midst of, or even after an outbreak is critical to achieving the overarching goal of preparedness and response. And the overarching goal of preparedness and response is preventing injury, reducing illness, stopping disabilities, and reducing death and supporting recovery after the epidemic. Some or most of the outbreaks can be predicted, and what needs to be in place for appropriate response and research can be thought of very well much in advance, leading to better research and better health outcomes altogether. Those planning to undertake research in an outbreak need to engage seriously and respectively with those whose interests are fundamentally affected by the outbreak. The national governments, research institutions in that particular area or country, local health services, voluntary organizations in the affected areas, members of the affected community. All of these have got to be considered, and they work together to look at the gaps that need to be addressed. Study protocols should be developed with the input of the local communities in order to ensure that proposed procedures are acceptable. Is this the right study for the location and the population or the subpopulation that is affected by the epidemic? Who has been involved in identifying the problem that the research seeks to answer? Will local population benefit from any positive finding? Is this the right decision for
Julia,
this?
you have 5 minutes left.
Thank you. How have local needs and concerns and preferences been considered? So all of this should be put in consideration as you're preparing for research in the outbreaks. Any exclusion criteria from studies should be clearly justified with reference to risks and benefits for the group in question. There should not be an automatic exclusion of vulnerable groups, such as children, pregnant women, or the elderly. In practice, exclusion may make these groups more vulnerable. We know of the situation of Zika virus immunization studies. They were leaving out the young children. They were leaving out pregnant mothers. Yet these were the people who were very much at risk. Use of placebos, where people are sick, and then you are using placebos with some of the people. So this again puts some of them at risk. So some words of caution. Research must be undertaken and supervised by qualified researchers. Research with human subjects should be carried out only by or strictly supervised by suitably qualified and experienced investigators. People should not be asked to take part in health research when their basic health needs are not being met, or when it is not helpful to reduce the research, when the research that is being carried out is not helpful in reducing these people's suffering. While doing literature review for this presentation, I came across this publication, and it has key components to research response in the context of health emergencies. This summarizes very well what one needs to do in preparing for research during outbreaks. I'm not going to go through this because of time, but at least this presentation will be provided. And of course, the references are also provided here. That particular reference is here, and anybody can check that out. It is a very good reference. Of course, there are also several training courses in research during emergencies. One of those is what is offered by the London School of Hygiene and Tropical Medicine, and I think the person in charge is Professor Jimmy Whitworth. Thank you very much for your time listening to me, and of course, I would like to acknowledge the different groups of people indicated in this slide. Thank you very much. Over.
Thank you, Julius, for that very good presentation. We've quite learned a lot, especially finding what to do in terms of research, where the gaps are, and the use of research in epidemics, and what to follow. Thank you very, very much. The questions will follow after the next speaker. If you have any questions, please hold on a bit. After the next speaker, we shall then have the questions for the two. If your question is very burning, you can post it in the Q&A. I can see we already have one. No, I think that's an introduction. Please, Augustine, the introduction is going to the chat. The Q&A section is for questions only. Our next speaker is Dr. Tom Lutalo, who is going to be speaking on the processes of obtaining ethical approvals to conduct research during epidemics. Like Julius did indicate, there are issues around the ethics of conducting research in epidemics, and so we need approvals. Tom Lutalo is an assistant director for research at the Department of Epidemiology, Data and Statistics at the Uganda Virus Research Institution. He's the current chairperson of the Uganda Virus Research Institute Research Ethics Committee and a senior investigator with Rakai Health Sciences Program. He holds a master's in statistics from the University of Leicester and a PhD in epidemiology from Makerere University. His long-term research interest is in the field of epidemiology of infectious diseases and reproductive health. And he has been mainly in prevention studies of HIV, sexually transmitted infections, and unwanted pregnancies, especially demographic consequences of HIV, effects on fertility, family planning use, and mortality at individual and population level. Tom, you're welcome to speak to us. We know you have a big experience in ethics over the years, and we look forward to learning from you. Thank you.
Thank you very much, Bernard, and good morning to everybody. I would like to thank the previous speaker, the previous presenter, Professor Julius Lutwama, because actually you've laid a foundation to my presentation. I'm here to share my experience when it comes to process of obtaining ethical approvals during epidemics. And I won't go through the definition of epidemics. Dr. Julius Lutwama has actually shared what we mean by epidemics and the difference between epidemics and pandemics. However, at the end of this, I'd like to share some critical ethical questions that are usually posed during epidemics. Then I'll go through what, as a research ethics committee, some of the ethical considerations that we need to explore when it comes to the review process. Of course, there are some submission requirements during the epidemics. I'll share guidelines used during the review, what we mean by fast-track review during epidemics, and thereafter, if at all one has received approval, what happens thereafter. I'll also share what research ethics committees have to go through when it comes to monitoring. Think back, all your research, planned research during epidemics. Who will get priority access to medications, vaccines, intensive care unit beds if there is a need? What are the obligations health workers have to work notwithstanding risks to their own health and the health of their families? How can surveillance, isolation, quarantine, social distancing measures be undertaken in a way that respects ethical norms? Are there any obligations countries have to one another with respect to pandemic planning and response efforts? By the way, what about those infected and the communities where the epidemic is? Should we consider this population vulnerable? So whenever we are discussing ethical issues, when we receive protocols and proposals for review, some of these questions are anchored upstairs in our heads as the process of reviewing, we embark on that process of reviewing the protocols that we do receive. So, what are the ethical considerations? Remember that even if you are to put together a research proposal during an epidemic, it will undergo the same review guidelines addressed in general biomedical research. Because countries do have guidelines that research ethics committees, protocol teams follow, and during the general ethics, during periods when there are no epidemics or pandemics, don't think that we shall ignore these guidelines. Actually, these are the foundations of the reviews that we carry out when we receive protocols that have been put together for research because of an epidemic or even during an epidemic. So ethical deliberations must take place within the context of the applicable national and international guidelines governing research involving human subjects. And Prof. Lutwama has also pointed out some references that could help anybody planning to put together a protocol or a research idea. The reviewers should base their decisions on the best available evidence at any given time. So when individuals, protocol teams put together their research ideas documented as research protocols, they should be following what at that point in time is available evidence that would help those affected as individuals, all those affected as communities. There's a need to streamline the ethics review process and to establish appropriate flexible mechanisms and procedures for ethical oversight, not limited to traditional research ethics committee systems. What I mean is that because it's an epidemic, we are in that period when everybody is a stakeholder. Even the members of the Research Ethics Committee, all regulatory authorities, they do need to put up flexible systems that will respond to the epidemic when it comes to the review mechanisms that could fast track the review process and enable the research ideas to be anchored in communities where the research is needed. When it comes to submitting for ethical review, don't plan to submit a concept. Don't plan to submit a document with only the objectives without a design. We do expect a full research protocol. Now, there are mechanisms that I'm going to discuss with you whereby we can even accommodate parts of proposals, parts of protocols, enabling fast tracking, enabling research teams to be in communities where the epidemic is. But we do expect ultimately a full research protocol with all the expected parts of a research protocol as documented in the national guidelines. Now, currently, epidemics affect not only those cases that may have been admitted or isolated, but they also affect the researcher. So there is a need to put together a risk management plan. This risk management plan details how the researcher is going to interface with the communities and those affected in such a way that you minimize the risk of infection. A risk management plan needs to be reviewed and approved by the Research Ethics Committee in the same way as a full research protocol. The review process needs to look out for evidence of collaboration between data sources. If at all, the research protocol, the protocol team is going to collaborate with, say, hospitals, okay, say, isolation centers. There's a need for the research protocol, the protocol team, to submit evidence that where they are moving to, the collaboration has been signed off by both parties. During epidemics, it depends on the type of epidemic. There are there's submission using established channels, whereby you may have to submit hard copies of the protocol, or even use e-channels, electronic channels, to communicate to Research Ethics Committee Secretariat, or even use channels whereby you can submit your protocol through using e-submissions. But in the majority of cases, whether you use e-submission, there's also a need to submit a standard number of hard copies for purposes of filing away, or for purposes of even sharing amongst REC members that may not have the capacity to access mails, emails. Yeah, some of the Research Ethics Committee members in our country may not have access to emails. So these hard copies, there is an SOP for each of the stages that you have to go through when it comes to submitting. And these hard copies will be forwarded to the members that may not have access to emails. And their review comments will use the same mechanism back to the Secretariat. There's a need when you're submitting the protocol team at the proposal and also the risk management plan to document research procedures as guided by epidemic-specific guidelines. These are usually guidelines that are put together by the ministry in conjunction with agencies like WHO or CDC. We expect an e-review by the Research Ethics Committee members, e-communication or discussion with the PI or study lead. And please don't think that when you are in a pandemic, an epidemic, you will not pay for the review. So normal submission fee structure will be followed. This might not involve expedited fee structure, but the normal process. The normal fee will be used when it comes to reviewing protocols that have been put together because of the epidemic. I will have to emphasize that some countries come up with epidemic-specific guidelines, how to conduct research during epidemics. Like for Uganda, the National Council for Science and Technology, the regulatory authority, has put together guidelines for conduct of research during coronavirus disease. And these are guidelines that form it's a benchmark when it comes to reviewing your risk management plan and your research protocol. Now, what do we consider during the review process? Prof. Lutwama has mentioned the need to scrutinize the competence of the investigators. This is very vital. There's a need to review, to critically look at the scientific merit and soundness of the study design, the objectives, how you intend to interface with the communities affected, how you intend to use the health workers, the frontline workers. All this has to be monitored. What is the standard of care as applied in different local and multinational research contexts? Is it appropriate to use placebo-controlled trials? Dr. Lutwama has mentioned the need to critically look, is it right to use placebos? If at all there is any medication appropriate for the cases? Is there no exploitation and is there protection of the vulnerable groups? The inclusion of quarantined or isolated individuals and migrant populations. How do you intend to include this? All this has to be critically reviewed when it comes to the process of reviewing the submitted protocols. we need to go through the standard review processes, evaluation of anticipated risks and benefits, the maintenance of confidentiality and privacy of personal data and information. All this has to be considered during the review process. For where there are biobanks to be established, what are the safeguards in place and intellectual property? The respect for autonomy and informed consent. This is normal when it comes to the standard review process, but even during the epidemics, we have to consider this. Are there fair and equitable benefit sharing and distribution? This could be between countries, the North and the South, developed and developing countries. Is there community engagement? This is very vital. You don't just introduce your research plans to communities without first involving the stakeholders. Have you declared conflict of interest? Now, when it comes to epidemics, what is it that we usually find that we have to consider? What is new that you find with epidemics that may not be considered or you find when it comes to the normal periods? Usually, there are changes in perceptions of risks, benefits, and trust, especially in the patient-provider relationship. This is usually something that we have to consider. Risks are higher during epidemics. There's a need for attention to organizational values like accountability and transparency. Remember that this is an epidemic. So we don't expect you to document in your protocol that dissemination will be at the end of a study. There's a need for timely generation of knowledge, which will be used in a timely fashion. Whatever you find out during your research, please have plans of sharing that knowledge with all stakeholders, because this will come out to shape how research is planned for during the epidemic and how you can go back to the cases and help them. Remember that there may not be sufficient time for standard ethics review processes. Some countries, some research ethics review can take 2 months, but during epidemics, we plan to have processes that will help the protocol teams have responses from the committees in a timely manner. So this flexibility, what is it that I'm talking about?
Tom,
I know that there are some protocols, pardon, Chair?
5 minutes.
Yeah, some protocols undergo full review, while others, we adopt a fast-track review process, usually between 7 to 14 days. However, even if there's a fast track, there's no dropping or narrowing ethical principles. There's a need to adjust balance between in-person and electronic communication by members. We do have to suggest that the use of pre-emergency repositories of study protocols or protocol parts, which could be submitted to RECs for ethical pre-screening. This has been mentioned by Dr. Lutwama for you to be ready in times of pandemics, epidemics. Currently, we use the rolling platform, rolling review of protocols, all parts of protocols, to prevent rigid protocols that could repeatedly be abandoned as new information emerges. We do create special emergency research ethics committee at national or regional level, and we organize joint review committees for scientific merit and ethical review, especially when it comes to clinical trials. In some cases, there could be retrospective rather than prospective ethics review, but there should be some safeguards. And these are usually for activities like population surveillance measures, disease control and prevention, and program development and evaluation. There's a need to differentiate between public health practice and research. So stakeholders should formulate plans to ensure that such activities receive appropriate and timely review, and that review by special committees with appropriate expertise and experience do examine the procedures and methods specific to public health practice. Training for research ethics committee members, regulatory authority members, and protocol team members. Now, after if at all there's been a joint review, say organized by the National Regulatory Authority, all these protocols need to be resubmitted to the IRB of record, the reg of record, which does a re-review and follows the guideline submitted to the National Regulatory Authority after the IRB of record has approved. And there will be use of e-communication of approval to the PI, and hard copies follow. And then the PIs have to submit it to regulatory authorities, like in Uganda, the National Council for Science and Technology and National Drug Authority, to register the research activity. We do expect protocol teams to institute risk management oversight teams and also institute biosafety teams. And these will be monitored by the REC and regulatory authorities. So the process of review does not stop when you submit. We even have to continue monitoring to ensure that what you documented in the research management plan, you are following to the dot. I will also share some references from that I used to put together this presentation. But these are also resources for those that are planning to put together research protocols for research during epidemics. Thank you very much.
Thank you, Tom, for keeping the time to the dot. I think we are very well on schedule. You've highlighted quite a number of things that are interesting. I think one of those last slides, you did mention something about the pre-epidemic proposals that can be used. I want to mention here, between Bonnie, Heather, and the TGHN team, that we have a platform where there are generic resources that one can use to quickly develop proposals if you need. And maybe they can post the link in the chat for the TGHN hub, especially for COVID-19. Lots of resources there that can be used to develop proposals very fast. We are going into the Q&A question, and we have one for Professor Julius, a question from Karim. Julius, maybe you can check the Q&A section. There's a question from Karim. For validation of treatment in a phase 3 clinical trial, use of placebo is also a need. So what would you do? What would you propose, please, to validate a clinical trial in phase 3 without a proposal, without a placebo, if no equivalent treatment is available?
Thank you very much. Thank you very much, Karim, for the question. I see there are 3 questions for me, even one from John Hongo, and also another one again from John Hongo. I am going to answer all these 3 questions. I'm going to try and attempt to answer these 3 questions together. First and foremost, I'm going to say I'm not really an expert at this. So I have not participated in any clinical trials, and I don't know exactly what they go or what they do about placebos during situations where one is testing the treatment, and if there is no other treatment, what happens to the people who are given a placebo? Sorry, I really don't have the right answer for that, but I believe before the end of the day, in these presentations, somebody is going to tell us exactly what they do in those particular situations. So I am not the right person to give a definitive answer about what is done. However, what I know is that this has got to first be discussed among the research team, and this has got to be very well communicated to the population, or at least to the team that is responsible, the researcher team, and of course to the Science and Ethics Committee, who would have allowed this study to go on. So there must have been, they must have struck a balance of how this is going to be done. On the question of how do you ensure that there is no automatic exclusion criteria, again, this is similar to what I have again just said. There has to be an understanding between the research team and where the research is going to be carried out within the group of people where it is going to be carried. If it is going to be carried out in a particular hospital, the people in the hospital, the health workers in the hospital need to know about it and how this is going to be carried out. And this should have been agreed with the Science and Ethics Committee that allowed this research to go on. So you must have presented to the Science and Ethics Committee that allowed the study to go on, convincing information on how you are going to go about this. About technology issues, during building systems to collect data, I think again it's the same thing. There has to be a lot of confidentiality, and this has got to be embedded in the proposal as you prepare it. How you are going to protect the rights of the participants from data, especially data that is communicated electronically, whether this data is going to be safe, so that people are not going to get a freedom to access this data, data storage. So this has got to be very well written out, how it is going to be done. Most often we use different levels of making sure that the data is to make sure that the data is well protected. For example, the area where it is collected, it may be given numbers. The laboratory where the data goes is again given another number, and the people who are inputting this data for storage are again given a different number. So the different people do not know the original numbers and cannot tell exactly where this information, what particular participant this information may have come from. Thank you very much. Okay.
Thank you, Julius, for those answers. Maybe to make a comment on the first question about placebo-controlled trials. Julius is a laboratory scientist, not a clinician, but I'm a clinician. I've done quite a number of clinical trials. Where there is no equivalent treatment and you don't want to use a placebo, I think it's, the guidelines say you use either standard of care as the comparator. So, and standard of care might be supportive treatment. So for instance, in the COVID trials, if you're going to try out hydroxychloroquine and there is nothing else you can use and you don't want to use a placebo, then you'll use standard of care, and standard of care might be supportive treatment, with ventilation and oxygenation, or, whatever is. So, but the research team usually will be able to find out what exactly to do. And there's a question from Ngoran Florence, during epidemic, how can clinical trials respect international guidelines for considering the fact that many people are dying and there is urgent need for treatment? Do we first use animals and go straight to test the new drug in humans? Probably Tom will answer that question. It's an ethical question. Tom, there is a second question for you. Considering the ethical considerations highlighted, how do we ensure informed consent among frail patients who are extremely ill to adhere to, take into account the following ethical requirements? I think capacity to give decision, participants must be given sufficient time to consider participation, provide adequate information, like free of coercion, free of undue influence, and competence. I think this is around How do you ensure autonomy of a critically ill patient if they are going to participate in research? Tom, you're welcome.
Thank you very much. And let me first emphasize what Bernard, you've actually alluded to. When it comes to placebo controlled trials, we usually have to consider the standard of care. That is a fact. Standard of care, if I were to introduce, that would be in the category as if it is the placebo, when it actually is the standard of care. Then you introduced a new intervention. When others get standard of care, others will get both standard of care and the new intervention. Then that way you will be able to analyze whether there's any benefit with the new intervention. Technology and consenting. There's a slide which actually I projected, which had the new guidelines, the guidelines during COVID, research guidelines during COVID-19 that were put together by our regulatory authority here in Uganda, National Council. And this is what scientists expect from regulatory authorities to respond very fast to epidemics, the use of technology. In that document, I was involved in putting it together. We explained the issue of how technology can be used when it comes to engaging frontline workers. You know, the protocol team may not actually be the ones that interface with the study participants in some cases. So you would leave it, say, to the protocol team members to engage with the patients, the cases, okay, in their protective, when they are putting on their PPEs, explain the study. They may not use paper whereby somebody can sign, but there's technology whereby somebody, the patient, can, if I told here, there's the comprehension has been tested and the person has understood, he can sign on a medium, which signature can be captured by maybe a tool, an IT tool, like a notebook or something like that, and which we've considered as something that is acceptable when it comes to evidence of consenting. So that's actually a document lists how you can do it. When it comes to protection, those tools that you use when you're interfacing with study participants, they are password protected. They have, because these days, actually, I will say it in simple terms, there are two levels of passwords, whereby you ensure that there's good protection of the data that you collect from the study participants. And then before you hand over or you send what you've collected as a frontline worker, they send electronically what they've collected to the protocol team members. In that way, the protocol team members could be receiving electronic form of the data collected. That is something that I will give you a link to, that the guidelines which help protocol team members to come up with a medium to use when they are interfacing with cases. Now, when it comes to who to contact, I've seen a question at the community level, community engagement. Usually, you introduce your research idea to a line, management line. If it's a hospital, you may have to discuss it with the hospital management. If it's the community, you may have to first use local administration, who help you engage the community to come up with a community advisory board specific to that study. The community advisory board are individuals who are trusted by communities to help them discuss the research idea and how the protocol team members do plan to engage the community, the participants from those communities. So in many studies, they put together community advisory boards. All they have to engage maybe hospital management before they engage with the cases admitted in either or isolation center management. When it comes to engaging with somebody who is critically ill, the review process has to consider the risk benefit. Is there any benefit if at all this study enrolls this participant? to the individual or even to the research community, clinical management. If there is, who can consent on behalf? We have to consider all scenarios, because if somebody is critically ill, there's during the epidemic, we might be losing out if at all we don't maybe get a sample from that particular person. So if there anybody maybe at the bedside, maybe a guardian at the bedside who can consent on his behalf, can we push it to the parent who is not at the hospital, but we explain to them the study, and then they'll consent on behalf of the patient, or to the hospital management. All these levels have to be considered when you are putting together a research protocol. Okay. When it comes to, what is it that I've forgotten? Multi-center studies. Oh, there are a number of questions, Bernard, that have come my way.
Yeah, I think the one from Abbas Ebo. How do we fast track approval process during an epidemic without bridging, yeah, the standard guidelines of research ethics?
Could I just come in as well here? It's Julian here, the co-chair, just to say that there will be further opportunities for question and answers after the following two presentations. So if the questions haven't been answered in this session, please don't worry, because there will be further opportunities to discuss these issues with a panel of four.
Okay, thank you, Julian. Tom, could you respond to maybe two more questions? The one from about fast tracking, and the last one from Abbas Abo again. First that one, then the last one, and we shall move on.
Fast tracking. There are standard operating procedures when it comes to expedited review, fast tracking, which involve REC members, research ethics committee members, and the protocol team members. What we do is that we don't follow, usually the review can take 2 months, a month and a half before you receive approval. When it comes to research protocols submitted during epidemics, there's full commitment of research ethics committee members to find time to review your protocol so that you receive a response or you discontinue with the discussion with REC members within something like between 7 to 14 days. It is faster than the normal standard review process. And this is something that we follow because we are guided by a REC standard operating procedure, how to review such protocols during epidemics. And this is something that you should put together where you are. Okay. Any other question? How do you mobilize rural or hinterland committees? Maybe non-existence, those committees. Be engaged. By the way, when you put on a hat of a researcher, please be prepared to face difficulties in terrain, difficulties in communication, and plan for it. If at all it's a hard to reach community, okay, then be a Power Ranger. Try to get to find means of reaching out to such communities. One thing is that if at all there is no e-communication, there is no email, there is no telephone, but if at all you can drive there, if at all you can reach those communities, don't introduce a research idea to communities without first engaging the community for them to understand why they are picked and why they are the individuals within communities. Some individuals are not all. Please engage these communities, reach out to them, because you as a researcher, you may be able to find funds that will enable you move wherever you are, from wherever you are to such communities. Okay? Put on that hat, please. Bernard, anything else? I think the rest we shall maybe type the answers.
We have, maybe we can take a break because we're supposed to break at 11:10 and we have about 2 minutes. I thought there is a question here which is interesting from Abel, the last one, Tom. My previous question is asked because we are currently carrying out a clinical trial. Before getting the approval, it took a whole lot of time in a pandemic where scientists and researchers are looking for solutions to address the pandemic. What are the possible ways to address this? I think, Tom, you have answered that one really. It's around fast tracking and people being available. Thank you very much. I think let's take the much needed break. The next questions will be addressed at the end of the next two presenters. Right now we are taking a break of 10 minutes and we shall be back at exactly 20 minutes past 11 for the next set of presenters. Thank you very much.
Hello and welcome back. Can people hear me?
Yep.
Great.
Yep, we hear you.
Yeah, excellent. Good. Good morning. Sorry for the glitch. Welcome, Julian here. So we've had a fascinating first two sessions. A couple of housekeeping things. If you do want to ask questions, do please pop them in the Q&A. If you want to introduce yourself, etc., please do that on the chat. So I'm delighted to be able to introduce to you the next speaker, which Jane Achan. Jane is a senior researcher at the Malaria Consortium, where she oversees and drives the research agenda and programs across 11 countries in Africa and Southeast Asia. She has a very full biography, and that's available to you from the organizers. But Jane is going to talk this morning about an absolutely critical topic in research, which is the safety of participants, which must always be front and center. So Jane, very much welcome to you.
I'll be sharing with you about the safety of participants and research teams during pandemics. So clinical research is vital during pandemics, and the research that is usually conducted may include research activities that had been planned or were ongoing prior to the onset of the epidemic, and also epidemic-related specific research activities. When the epidemics occur, especially as a result of novel pathogens, it presents an unprecedented challenge for research. And this is because there is a need for rapid development of new diagnostic, preventive, and therapeutic strategies, but there's also a need for clinical and epidemiological studies to enhance understanding of the disease. And as epidemics spread across the world or the different regions that are involved, the critical importance of research and development in the response to such outbreaks is spotlighted. We have seen that epidemics usually require a swift response from authorities to manage the spread of any such infections. In many countries, lockdowns and restrictions on movements are usually enforced quickly to try and slow the spread, and this may sometimes include restrictions of movement to also health facilities. And in such context, safety and the principles of do no harm are critical for both research and clinical care. And of course, for the setting of research, it's the safety of the participants and the staff that should be the first priority. Now, there've been a number of responses to the epidemic. We all know that at the start of the coronavirus epidemic, especially in countries like Uganda, there was a temporary pause in some of the clinical research activities. And these decisions are taken sometimes at the institutional, but also country level for a number of reasons. One of the reasons is to eliminate non-essential contact to prevent study participants and research staff, but it may also be to shift the focus from routine research to more epidemic-related research, but it also allows for changes, necessary changes in hospital or research clinic settings to be adapted, especially to ensure that safety measures are enhanced. So what are some of the safety concerns that we as researchers should be thinking about? Of course, research participants and staff are affected by epidemics in many ways. One thing that we need to highlight that is often ignored is mental health. Research participants and staff may feel stressed and often need counseling. And why is that? There are several negative psychological effects, especially regarding quarantine. People have reported post-traumatic stress, confusion, and anger. This has been reported within the setting of the current coronavirus pandemic, but also in the previous epidemics like the Ebola epidemic. A lot of segregation and isolation has been observed. Other factors like loneliness and isolation, especially for people living alone, but also worry and concerns that they or family members will contract viruses or the different causative agents. So the possibility of mental stress is very critical and should be monitored and actively addressed during the planning and during the conduct of these studies. But also for clinical trials, ongoing clinical trials, it has been reported that limited access to investigational products during lockdown or during movement restrictions are also a bit of concern and also have safety implications. And in this kind of settings, alternative arrangements need to be made to assist participants. And there are also safety concerns regarding risk of exposure and transmission. And of course, this risk varies according to the different types of the interactions occurring during the study, how much close contact exists, what is the number of contact between the different individuals, both within the research team and the participants involved. What is the use of personal protective equipment in these settings? Are these readily available, not just for the research staff, but also for the research participants? And of course, when you look at the risk of having more severe disease also causes concern, and this varies at the individual level with some characteristics clearly associated with greater risk. So this knowledge is quite vital. Which members of the research team or which participants should you not be exposing, and who are those who may be at a higher risk of severe disease? But also it's important to note that the biggest challenge may actually not be within the labs or the clinics where we work, but also the safety in getting to and from these sites. What are the risks involved in public transportation if we are expecting individuals to move from their homes to the research clinics where we work? Those should be addressed. And there are a number of safety concerns that are related to new investigational products or some unproven experimental therapies. What are the potential toxicities that the participants will be facing? What are the decisions or the pathways of decision making that should be used to determine what the risk-benefit analysis for some of these unproven therapies? So in the midst of some of these considerations, like the first two presenters have mentioned, there have been considerations on what kind of research should be continued and what kind of research maybe we may need to pause until later. And indeed, these decisions are quite critical, and it's usually a tough choice for principal investigators. And really the responsibility for these kind of decisions is based on the principal investigators who need to weigh the risks and benefits within the context of the epidemic. But the ultimate objective is really that the PIs should know or should consider that they must provide a safe environment and address the psychological needs, not just of the participants, but also their research teams. A lot has been mentioned about community engagement, and indeed, community engagement is quite essential in these situations. A community involved in planning the process of a study and a community that is informed about the risks and benefits is more likely to trust the research process, but also trust the research teams that they are working with. So some of the general guidelines that have been shared within the wider community, largely within the current pandemic, and it's that the first guideline is really staff and participant safety. That is the ultimate. And several regulatory agencies have stated these statements, like safety of the participant is of primary importance, and the risks of involvement in the study should be weighed against the anticipated benefit for the participant and the society. That must be critical. And then, of course, we know that to ensure safety for both the research participants and the staff, there may be need for some protocol amendments. And within these protocol amendments, the objective is really to ensure that any hazards should be minimized or eliminated with a goal of protecting both the research staff and the participants. And then, of course, there are some changes that also need to be made in terms of study management. What methods will be used to communicate with participants? Should there be physical visits? And if so, this should only occur if it's necessary. Where possible, can you deliver treatments within the participants' homes to really minimize travel and minimize undue exposure to risk? And of course, communication is key. If there are any changes within the context of the study or any changes within the conduct of the study and any implications that may have, all these should be adequately communicated to the patients and the participants and also the different research sites. So we've had a number of challenges and issues related to safety of both the participants and staff, but what can be done in some of these settings? And we know that indeed it's very important all research participants and staff must be informed of the risks and educated regarding the transmission routes of the different agents we are dealing with, and what are the kind of symptoms that they should be looking out for the infections of the different pathogens. And it's important that this information is provided in the most transparent way possible. We should not be hiding any information from the participants, so we should be able to provide this information as transparently as possible. And we also need to take care of the vulnerable populations like pregnant women or individuals that have comorbidity. These are particularly at risk, and these should be protected. Unnecessary visits to the study clinics should be avoided as much as possible, and maybe they should be met within the confines of their homes if exposure externally is a big problem. Do we need to have face-to-face meetings with participants? I think these are things that should be conducted only when it's absolutely necessary, and where possible, maybe change to phone calls or online meetings, depending on the setting and what is appropriate for the different settings. And of course, appropriate personal protective equipment is mandatory to help address some of the challenges and concerns, especially with risk of exposure. And then, of course, at the different trial sites and the study clinics we work, it's important to reduce the density, reduce the population density at these sites. We need to make sure there are never a lot of people. Where possible, we need to ensure that at any one time there's a sizable number, depending on the size of the facilities we have. And of course, different study teams have considered stretching participant appointments. If the clinics are working 4 days a week, maybe this could be stretched out to 7 days a week. And the ultimate goal is really to minimize the number of people in the building at any one time. For pathogens that are airborne, of course, there's a call to shift from indoor to predominantly outdoor activities where possible. Essentially, different approaches to optimize the ventilation to kind of reduce transmission within those kind of settings. Of course, with some of the changes, there's also a need to revise the consent forms. We've just heard about the ethical approval procedures. Some of these changes may require revision to the consent forms that we give these participants. And this is to make sure that the participants have sufficient information to make informed choices about what they're comfortable doing in the setting of the epidemics. And of course, the consent forms should include good detail about the potential risks that these participants are facing, as well as the measures that the research team is taking to protect the participants within the setting of these epidemics. And of course, it's also critical to make sure that participants understand that they can withdraw from the study at any point. That flexibility and ensuring that there is adequate understanding within these special circumstances is key. Of course, a lot of what I have discussed previously relates to general research activities, but there are also some concerns that are core to epidemic-related research activities. And when you're working within the diseases that are causing the different epidemics, these particular research activities also raise specific safety concerns for research staff, as the risk of exposure is particularly high within this kind of research activities. And in these settings, the overall objective should be to reduce to the lowest reasonable practicable level of taking preventive measures in order of priorities. You do not want research staff infected just because they are actually conducting research within a particular epidemic disease. So effective training and communication to ensure that all staff understand the related safety procedures are needed. And of course, the use of appropriate infection prevention and control processes and personal protective equipment, depending on the level of exposure to the different units. And in these situations, it's also quite critical to ensure that there is effective workforce management. You have to ensure that the groups are working in shifts, and also to ensure that they work in teams. For example, a buddy system whereby you want at least 2 people to enter the lab at the same time, just to ensure that at that personal level, there's a bit of co-supervision and co-support to avoid mistakes. And then also for the participants within the setting of an epidemic research, the harms or the safety concerns here may be related to breaches of confidentiality or violation of privacy or discrimination or stigma as a consequence of participation. We've been conducting research within the context of the COVID-19, and we've had participants who do not want to be dropped home for fear of the neighbors knowing that they are actually patients who are returning from a prolonged stay in hospital. So all those are concerns concerns that need to be taken care of and covered appropriately in our operational aspects of the research we conduct. Of course, when we listen to all the talks from the morning and this talk, it sounds like there's a lot of chaos, and research within the setting of the epidemic may be difficult, but it's good to note that in the midst of chaos, there's also opportunity. There's a lot we've learned on how to manage these challenges and how to address some of these safety concerns. Of course, within the learning processes that have taken place, there are guiding principles for conducting human research during these pandemics that we've learned about. We've just heard about the ethical approval processes that have been tailored to suit the pandemic, but also we've learned that the safety of research participants and staff is paramount, and there are a number of guidelines available to ensure that this safety is adequately taken care of. We also know that the risk of community spread, including spread to researchers themselves, must be minimized. So protective equipment, IPC protocols have been developed to ensure that the risk of transmission has been minimized. And of course, at the global and the national levels, there are policies and practices that have been designed and should be implemented in a way that attends to inequalities explicitly and proactively. And of course, different groups have developed best practices, but of course the challenge now is that these best practices need to be shared widely within the research community so that no group is starting from zero, but there are a number of best practices that can be shared globally and across the borders. Thank you very much for your attention.
Jane, thank you. A wonderful overview of the kinds of safety concerns which absolutely have to be front and center in research, and of course, particularly when we're talking about research in highly infectious diseases. Just a reminder, if you have questions, do pop them in the Q&A box, and we can pick them up later. But now, what I'd like to do is to introduce you to a colleague and friend of mine. Sorry, excuse me, Katherine Wright, who is an assistant director at the Nuffield Council on Bioethics here in London. She and I work together on the Nuffield project on research in global health emergencies, and I'm very much looking forward to her presentation. So over to you, Katherine.
Thank you very much, Julian, and to all the attendees, and thank you very much for the kind invitation to join you. Thank you again for the opportunity to share some of the work the Nuffield Council did on this challenging question of how we do research ethically in emergencies. I should apologise that I think because of the time difference and domestic issues, I was only able to join about 10 minutes ago, so I wasn't able to listen to all the previous presentations. But I was really struck with a lot of overlap with the previous excellent speaker. And I think there's some very interesting ways in the way that what we think about ethics, I think perhaps needs to be broadened out to cover many of the issues that were just being covered. And I hope to explore that a little bit more in the next few minutes. So the aim of the Nuffield Council on Bioethics work that Julian referred to and that I'm drawing on here was to identify ways in which research can be conducted ethically in emergencies, recognising that there's a real dilemma here. On the one hand, good quality evidence is absolutely essential for effective emergency response, both at the time of the emergency and in the future. And I think just the recent announcements on vaccine studies, for example, illustrate that very, very vividly. But at the same time, emergencies are highly non-ideal circumstances in which to conduct research. So there's a real tension here about how we achieve that research. And I think historically, fortunately not so much today, but historically, emergencies have been seen as an inappropriate or unethical time in which to be conducting rigorous research. So this was a 2-year inquiry supported by an international and interdisciplinary working group, and it led to the publication in January this year to a detailed report and policy recommendations. And with some rather strange coincidences, we actually published that 3 days before COVID-19 was declared by the WHO to be a public health emergency of international concern. I don't think we thought during the process it would be quite so timely. So a lot of our recommendations were aimed at funders, at governments, at others who have the power and influence to change things. And I think an important part of our report, and I'll keep coming back to this, is that ethics isn't just about what happens on the ground, it's also about what happens at policy level, and what our funders, what our regulators allow us to do as researchers or make us do as researchers. But we also produce materials that are more directly aimed at researchers and at others on the ground, recognising some of the sometimes intractable dilemmas that we will face. and trying to find a way to at least think through those. And as part of that, and with the Global Health Network, who are co-hosting today, we included an e-learning course, and we developed an e-learning course in several different languages. And I'm sure Bonnie Baker will come back to that at some point. A quick word on the breadth of contributions to our inquiry, which I think is very important for any legitimacy we might claim for this work, because of course, the Nuffield Council on Bioethics is based in the UK, and we need to recognise that those of us and the staff working there are inevitably coming with our own wealthier countries' perspectives. So during the project, we had input from over 30 different countries, as you can see from the marks on the map there, via an open call for evidence, via meetings held in the Philippines, Singapore, Lebanon, Senegal, the US and China, bringing in many people from different countries in those events too, and through an external review process. So I think we did what we could as a fairly small UK organisation to make this as an inclusive a process as possible. But I think there's a great deal still to be done in exploring how our thinking might have resonance, might need to be nuanced in different areas of the world. So an important starting point, coming back to what I said about research emergencies being a non-ideal set of circumstances in which to conduct research, was to identify what it is that's different or special about emergencies. And the working group looked at a whole range of different emergencies. Obviously, our focus here is on infectious disease outbreaks, on COVID-19, but we also looked at natural disasters, at human-made disasters such as conflict. And we identified a number of common factors that we thought underpinned why research was so difficult and why we needed to think perhaps differently or find different ways through thinking some of the ethical challenges. And there were the disruption from some kind of norm, recognising the norm itself may not be stable, but the emergency itself disrupts what was there before. The level of health need, both at individual level and at population level, and the tensions that can bring. In particular, the time pressures to act and how those are often really in conflict with our usual research procedures and timelines. The question of uncertainty, and the idea it's very hard to know when one has enough information to move forward, when one should wait, or when actually there are more risks or more dangers in holding back. And then I think really importantly, the human element of all this, the distress that emergencies generate in all of us, and the impact that has for how we act as researchers, how we behave as participants, how we behave as broader members of the community, and building that into our way of thinking ethically. When emergencies are global, where they involve many different countries, many different organisations, whether all those different organisations and countries working within one area, or as indeed with COVID-19 in a genuinely global pandemic, that brings additional ethical challenges because of the scope for tensions over control, responsibility, legitimacy, question about who is calling the shots, who has power, who has money. And that brings me, I think, to the most important thing I'd want to say in this presentation, which is that ethics is not just about ethical review. Ethical review is very important, but it's part of the bigger ethical picture. And in particular, we need to think about the macro questions, the political questions, if you like, about power and influence, about whose voices are being heard, as well as the more, you might think of micro technical questions of trial design, review, recruitment, and so forth. And I think that particularly arises in the context of power differentials between resource-rich and resource-poorer countries, and the complex ways in which that plays out in terms of how we share data, how we share samples, who has the intellectual property, who accrues the benefits ultimately, with some real impacts there on trust and fairness. So moving on then to the ethical approach that we took in this project. The working group developed what we called an ethical compass to guide decision making, both at the level of policy, recognising that these factors also affect how funders, how governments, how the humanitarian sector should work, but also for those on the ground, recognising that we will all be following our usual ethical guidelines from our professional bodies, the international guidelines that we all look to, but that at times there may be no clear way forward for us because of the kind of issues I alluded to earlier around disruption, around distress, around time pressure. And we identified these core values that should help find a way of thinking through those dilemmas. And I think one of the things I'd like to emphasise is that these values emerge very much from the evidence and the experience that people shared with us, particularly actually in a workshop we held, or we were part of with ALERRT in Dakar in Senegal 18 months ago about community engagement, where I think some of these points came through particularly powerfully. So these are very much bottom up, not sort of top down values. So just working through the compass briefly, first thinking about helping reduce suffering. This is the fundamental reason why we're doing research in emergencies. We're not doing research because something's interesting. We're doing it because we hope it will make a difference. And that brings really important questions of power and perspective. So whose needs are being met? Who's defined these needs? Are they, is it people a long way away thinking about what people might need, or is there actually local input? And are these the most important needs? Because we know some research drives out others. There's only so much space or capacity for research. And if one prioritises studies that are less important, that has real opportunity costs. Secondly, thinking about others, respect for others as moral equals, which we abbreviate there to equal respect. So this links with the question of who's defining suffering and how we prioritise goals. It prompts us to ask, how will communities be involved in planning the research? And I was delighted to see, as I came in on the previous presentation, how that was being emphasised. How will research design be sensitive to local values? And what can be done to ensure that participants are treated respectfully throughout the whole research life cycle? We often focus a lot on consent and recruitment. What happens after that and before that as well? And then finally, in terms of fairness, thinking about this in a number of different heads, thinking about distributive justice, the benefits and burdens of research, particularly thinking about who actually is going to gain the benefits of research. But also in terms of discrimination, are people being excluded? In terms of process, are the processes used seen to be fair? And then in terms of working relationships, particularly between international, national and local researchers. Picking up the second bullet point there on the slide, I think it's really crucial to recognise that there are no easy answers here. These values will often at times be in tension. I think the key point is that none can simply be overridden. There may be times when we want to go all out thinking this is the most effective way of reducing suffering, but we cannot ignore questions of fairness and respect in doing that. And we also have to recognise the opportunity costs of not doing research. I think one of the starting points for our project was this awareness of quite how many people felt that it wasn't ethical to do research in emergencies, it was safer not to. I think the point of thinking about the lost opportunities to reduce suffering, if one can do so in fair and respectful ways, is something we must take account of at all times. So the report itself, which is a really quite substantial document, then goes on to look at how this compass might play out in 6 different areas of research conduct. So thinking about more inclusive ways of both setting the research agenda and then designing and reviewing studies. Thinking about consent and how that might fit in what we call the wider ethics ecosystem, recognising the central importance of consent, but not allowing everything just to hang on consent, thinking about wider responsibilities too. Thinking about equitable collaborations and partnerships, particularly where those are between resource-rich and resource-poor institutions and parts of the world. Thinking about how that plays out in sharing of data and samples. And then really importantly, in terms of better support for frontline workers, for those who are actually doing the research. And again, I picked up some really important practical elements of that in the last presentation. I'm obviously not going to try and talk about all those in my remaining sort of few minutes. What I'd like to do is just pick out a few of these points as they might apply to researchers and ethics committees actually there on the ground, and then touch on this idea of what wider responsibilities there might be, including in terms of support for those in the front line. So what might all this mean for researchers? First and foremost, we highlight the importance of community engagement, of encouraging the involvement of local communities from as early as possible in the research process. Our concrete recommendation to ethics committees is that as a minimum, they should expect researchers to have had that kind of local engagement in developing sensitive and appropriate tools for consent. So communication tools to understand the study and consent procedures, whatever form that might be most appropriate for those to take. But that's very much as a minimum, and we would ideally like to see, and we would think the greater the chance of the research being conducted successfully and ethically, where communities have been involved as early as possible. We also recognise that that depends to a certain extent on funders and on being flexible enough to enable that kind of process to take place. And we address that in our recommendations to funders. Second, thinking really closely about inclusion and exclusion criteria, and not automatically excluding groups who are traditionally considered to be vulnerable, thinking rather of the risks of both inclusion and exclusion. There will at times be a reason to exclude particular groups because the risks are simply too high, and that needs to be clearly justified, but sometimes that will be possible and appropriate to justify. But in terms of thinking about the risks of exclusion as well as inclusion, in social science research, the risks of silencing particular voices. In interventional research, the risks of not understanding, not knowing how interventions might work in particular groups. And in the context of the last few days, the various announcements about the vaccine studies, I've been very struck by the number of older people involved in both phase 2 and phase 3 studies, and how important that's been in understanding how the vaccines will work in the populations who are most vulnerable to serious disease from COVID-19. And again, just picking back to the previous presentation, I think when we think about including people that perhaps historically we might have thought it's safer not to include, it's really important to think how we then minimize the risks, and thinking about, yes, whether that's about home visits, about how you effectively moderate your study in order to make it safe for someone to take part, rather than thinking this group bring extra risks and the safest thing is not to include them. Moving on then to the question of consent and wider questions around recruitment and inclusion. I think we need to consider whether the information and procedures proposed for consent are the best and the most sensitive that are possible to achieve in the circumstances. And there are many good examples from outside the emergency context of ways in which consent can be done really well. Consent is not just about a form, it's about sharing information in the most appropriate ways. It's about making sure, to the best of one's ability, that a person is making a free choice and is making a free decision to take part. I think also we need to think about the limitations of consent. We need to recognise that in some circumstances, people, and particularly in certain kinds of emergency, people may have very few choices and they are likely to say yes, whatever the process. Now, that is not a reason for not having the best possible process. We have a moral duty to have the best possible process. But I think we also need to recognise the constraints under which people are acting and think about other ways to ensure that participants are shown respect as moral equals, that are, as far as possible, in partnership with you in research. We're doing research with people, not on people. And that brings me back to the previous slide and thinking about the ways in which community members have been involved in developing the research. I think the more involved people have been in the earlier processes, the more confident we can be that the study is really meeting local needs, it's sensitive to local concerns, and it's not likely to be exploitative. And I think that can give us a lot of confidence that even if we know realistically people will say yes, however good our consent processes are, but nonetheless what we're doing is a fair thing to ask. And that brings me to my third bullet point there. I think recognising that consent can never be everything. I think we suggest so a final, almost intuitive check to ask ourselves, in all the circumstances, is it fair to ask people to take part in this study? Can I think about my study and think this is a fair thing to ask somebody to do?
5 minutes, Katherine.
Thank you very much. And then finally, I think a really practical issue that comes up over and over again, but often seems to be neglected. But if we're asking people to take part in our research, to invest their time and emotional energy in answering our questions, quite apart from any physical risks and burdens, and we might be asking them to take on, we owe it to them to tell them later what they found out, how they've contributed to future knowledge. So it's crucial to communicate well throughout the full length of the research process. And again, one of our recommendations to ethics committees is they should expect to see communication plans across the lifetime of the research when they're asked to authorise studies. Moving on then finally to this wider question of the duties of other, what we call duty bearers, so funders, employers, governments and others. And we highlight the imperative for better support for frontline researchers themselves. And again, I was really pleased to see practical points about that in the slides I caught just before I joined. So we argue for duties for employers and others to protect the welfare of frontline research workers, including supporting them in dealing with ethical challenges that arise. And that's both in terms of providing mechanisms for those challenges to be explored and for people to have support in working through them, but also in dealing with the moral distress that will often arise for people and dealing with really quite extreme difficulties on the ground. And then we touched, I think only briefly, but it's a massive issue, on the challenge of differential terms of employment between local and international workers, which came up as a massive issue in our call for evidence 18 months ago. And we suggest that equal respect clearly underpins equality of treatment, but we also identify how levelling up, for example, in terms of international salaries, brings its own challenges. If you were to bring all levels up, all salaries up to the level of international ones, that would then undermine local health economies and create more injustices. And this is an area where far more work is needed, but we made 2 provisional recommendations, one around transparent justification for any kind of differential treatment, for example, with reference to different living costs, for example, in salary, We identified that in some aspects, it's very hard to see how you could ever have a justification for staff members from different areas of the world or from different employers having different treatment. And that will particularly arise in terms of safety and welfare. And again, the previous speaker picked that up very practically in terms of PPE, in terms of working practices, and so on. And then finally, just touching on this bigger picture of the role of duty bearers, such as funders, governments and others, and the call for action that we published at the time of our launch, in which I think key funders like Wellcome, like the African Academy of Sciences, like Fiocruz in Brazil, some of the humanitarian sector publicly aligned themselves to. And we highlighted 4 headline recommendations there, that funders should work in partnership with governments and others to ensure that participants' basic health needs are being addressed through the response efforts. We felt that was a minimum requirement for research to be ethical. We cannot ask people to take part in research when they're in a completely desperate state with no access to the basics of life. We need to invest long-term in community engagement mechanisms. We need to promote equitable collaborations between research partners in low and high income settings. And we need to support emergency planning, including robust health and research systems. When I reflect on those now, this is what we pulled together 9 months ago as we launched our report as being our headline messages. I think what we've learned from COVID is just quite how important those issues are. Thank you very much indeed.
Thank you, Katherine. A very rich account of some of the kinds of ethical challenges that inevitably arise during this very high-pressured research. Before we go on to take the questions, just a couple of things from me. It would be great now if all 4 panelists could come together to respond to some of these questions. I believe we've got about an hour of time, so a lot of some good time to get into some of these questions. So if I could ask all panelists who are still with us to switch on their videos and join us, that would be tremendous. And we've got 4 or 5 questions so far, so I'm going to take them one at a time. I may add in a little emphasis myself now and again. But first up, I mean, one of the big challenges we saw in one of the earlier slides, the kind of slightly shocking image of health workers being protected by armed policemen to stop them being subject to violent attack by members of the community. Trust, therefore, is front and center. And we've got a question here from Achan Edwin about different kinds of community engagement. Achan says, could you specify the different forms that community engagement could take, please? But I would very much welcome reflection from our panel on the broader issue of community engagement, because as we have seen, and we've seen throughout, and we see it now in COVID, matters of trust are so essential. And it seems to me that community engagement is a pillar of developing that kind of trust. So I wonder if our panel could comment on that. And also, please, any more questions from those participating, be great to hear from you. So could I start with perhaps with Jane and ask Jane her views on community engagement?
Yeah, I think, as mentioned, community engagement is key. And the greatest issue here is developing trust between the communities where we work, and not just the research teams, but also the other health representatives within these communities. And how do you best get entry within these communities? I think understanding the community power structures is quite key. Understanding who the gatekeepers of these communities is quite key, and who the opinion leaders in these communities are quite key. So it's really the approach and your entry into the communities, and ensuring that there's complete transparency in your communication of both risk and the issues that are related. So it's really, what are your entry procedures? How transparent is your communication with these members of the communities? But also using members of the community, opinion leaders within these communities to really drive the messaging across. Those are the things that have worked in some of the studies we've worked on.
Thank you very much. Juliet, Professor Lutalo, could I ask you for your thoughts on community engagement and any concrete examples of where it may have been effective, or where it may have been less effective?
Well, thank you very much. I have been involved in research activities, particularly after outbreaks, because I have been following survivors of diseases, like survivors of Ebola, survivors of Marburg over long periods of time. And of course, first of all, these the survivors are people who, like, most often are discriminated, and they don't normally like to have people coming to them and again reminding them of what they went through, and of course they feel like not much has been done for them even after the outbreaks, and then you now want to come and get information from them. So you have to get a way of how you really communicate with them, for them to understand that what you are doing, the information we're trying to get from them is information which you can only get from them. It is not information that you can get from elsewhere, and that this information is not only useful for the people who are looking for the information, but that this information is useful for both them and the communities, and for future research work, not knowing when again another outbreak or another epidemic is going to occur. It may occur in the same community, it may occur in another community, it may occur like any of their people, their members of their families who are not exposed. For example, if it is an Ebola outbreak and other members of the community who are not exposed, they may get exposed. So you have to approach them and really discuss with them, convince them that the information we're trying to get from them is information that is going to be useful to them, it's going to be useful to the community, and it is going to assist in any other future outbreak. So that relationship which we build with them is very, very critical. I know I have followed survivors of the first Ebola outbreak in Uganda, in northern Uganda, for about 20 years now. And we have built a kind of relationship that anytime they see me, they are no longer worried anymore. Even if I'm going in with different researchers, I just have to explain to them that these are researchers who are coming up with a different question, and all the time they understand this. And I've built this kind of relationship virtually with all the different survivors of different viral hemorrhagic fever disease in the country. And so that the communication you have with the people, whether during an outbreak or after an outbreak, because during the Ebola during many of these outbreaks, I go there first. I go there and talk to these people, explain to them what the disease is and how we expect to assist them. And of course, for those who survive, they already know me because they've been seeing me during the outbreak. So after the outbreak, again, it becomes easier communicating with these people. But it all depends on how you have communicated with them during the outbreak. So that communication with the community is very important. Thank you.
Oh, marvelous. And could I just ask Tom, from your perspective, your understanding of the ethical regulatory systems, how much attention is paid to community engagement through those kinds of regulatory structures that you were commenting on in your talk?
Unmute.
Sorry. From the regulatory platform, we do expect for protocol team members to involve community advisory team members, community advisory board members, but we would like to get to know how they arrive at those that form community advisory boards. We have to be very careful. When you go out to the community where the research is going to happen, it's not that you go straight to the local administration office and you expect that those that you need to participate in the research or in your activities will listen to that cadre, that type of cadre. Sometimes we expect the process of putting together to be submitted to our IRB for discussion, okay? There's no forcing anybody, but the mechanism you use to reach out to all those that are potential participants, and even those that are not potential participants, for them to be comfortable for your activities to take place in their communities, we need to know. Another element that I've experienced, part of a research team, the Raka Health Sciences Program, and also being part of response teams. You know, when you are in the community, you identify community, you can engage the communities to identify the community advisory board members. But when the research teams are out there in the community, they still find that there are some elements that will not believe in whatever the community advisory board members are saying, or even you, the researcher. And I find the model of bringing such individuals nearer to your, say, data and sample processing platforms. Such a move opens up their minds. Instead of you engaging them only in their community where they reside, if at all you are involved in, say, sample collection, if at all you are involved in data collection, can you identify some individuals who have proven to be tough and you invite them to your labs so that they witness how you process the samples? You are not selling, you are not actually infecting others. That process, it brings them nearer to you, the research protocol team members, and when they go back, they will become your ambassadors. Sometimes that we've seen has been very helpful. Submit.
Marvelous, thanks very much. Katherine, could I just ask you, community engagement, when we were working together on the Nuffield project, community engagement was something that was really quite at the center of the project, I think. I wonder if you could make a few comments, if you wouldn't mind, about the kind of relationship between consent and community engagement, because you mentioned in your talk very helpfully that consent is a kind of, is a sort of, sometimes it doesn't quite fit the moral purposes that you want, that you're kind of seeking to realize during this process. And I wondered if you could possibly just make a few comments about the relationship between consent and community engagement.
Sure, thank you, Julian. Yes, I mean, I think the first thing to say, I think is as soon as one starts challenging the central role of consent, the risk is that people are assuming you're saying consent isn't important. So that is absolutely not what we were saying. You cannot go ahead ethically with research if you're not confident that the person in front of you, has given as free a consent as possible. You have a real duty to provide the information, the explanation, and the framework in which that's possible. But I think in the UK and the US, we see ourselves so much as autonomous individuals who make all our choices completely freely. I still don't understand how anyone can think that, given how any of us surely make decisions with our families, thinking about how others around us might want us to behave as well. So I think in many ways the individual aspect of consent can be over-egged, if you like. Of course, we're influenced by those around us, and we are influenced by our situations. So if one is in a situation where, because of whatever the emergency is, our entire lives have been turned upside down, however good our consent process is, we cannot be as confident as we might be in other circumstances that the person is, that this is something that they are absolutely freely choosing to enter into. So I think in that sense of saying consent is front and center and absolutely crucial, but it can't do all the moral work, which I think sometimes, particularly in more Western approaches to ethics, where we just think about these things almost being like a contract between the sort of the researcher and the participant. I think that's a really unhelpful way of thinking about things. So coming back to the community engagement side of things, it seems to me that's about looking first about, you know, what is it we're asking people to consent to? You know, can we be confident that this is a study that actually is meeting local needs, that is sensitive to your local concerns over how it should be conducted, that has thought about appropriately about inclusion and exclusion. And it seems to me it's very hard, you know, even within an individual country. I think one of the things we kept being told during our project is we think about the major gulfs between researchers in one country moving into another, but there can be equally big gulfs between highly educated researchers from capital cities, you know, moving into more remote parts of their own country. And again, you know, applying this to the UK under COVID, you know, the sense of there is a big gap between some of the people doing research and people whose livelihoods are being closed down by all the COVID restrictions and a lack of trust there. So these things apply, I think, in many different environments. So, I mean, going back to your question, Julian, I think both are absolutely crucial and they do fit together, that the more possible it has been to actually build trust and have meaningful engagement, the more likely you are to be offering something which people will, you know, be very able to consent to, regardless of the constraints in which they're operating under. If I may, there were a couple of other points that just I was thinking of when the other speakers were responding that emerged from the community engagement workshop we had in Senegal 18 months ago, which, as I said, was very influential in the work we did. One was input we had from Liberian colleagues about thinking about the diversity. When we talk about community, I think it's very easy to think of a homogeneous whole, and clearly communities are incredibly diverse and fractured and have their own power relations. And one of the distinctions I found really helpful there was between gatekeepers, between those who have formal roles and whom it is absolutely right that one has to go through to show courtesy for local legitimacy, but also looking for those with informal forms of influence, who may not have an officially recognised role, but will be influencing others, whether it's through, you know, professional associations or job associations, whether it's through youth groups, whether it's through religion, but the different ways in which people influence others. So I think thinking about that, I think sort of adding very much to what Jane said there. The other thing that really, I think, really shocked me as an example that was shared with us, and I think is crucial on this question of trust, was where one has engagement processes and one invites people to give feedback on an emerging study design or on what appears to be an emerging study design, and then say, well, basically that's all very interesting, but it's all been set at head office. I can't change that here. You know, this is a multi-site trial. You've said this is really important, but we can't change it. I think being really honest about what is up for changing in a study or for developing in a study and what can't be changed is absolutely crucial for trust. Because I can imagine you're a little less helpful than having really open conversations, learning how you might need to tweak your study to make it appropriate, and then say, sorry, you know, we can't do that. The funders or the whoever's managing this study from another country or continent says we can't do that. So that question of being really honest about those possibilities and being able to respond to feedback seems to be a key part of trust.
Great, thanks, Katherine. I have got a question here for, I believe it's for Tom, related to this. So Tom, it's from John Hongo, and he said, please ask this question to Tom. Are there any political challenges met during research protocol discussions with community advisory team or engagement? So Tom, any thoughts on that? Oh, I should also say we're probably going to reduce the Q&A to 45 minutes to just so you can have a longer lunch break. I'm sure you'll be delighted. So we will be closing this discussion in about half an hour.
Yeah, thank you, Julian. And challenges, different dimensions of challenges are faced when one is engaged with the community advisory board members. For one, membership. There's a school of thought that a community advisory board should be a link not only between the protocol team and the communities where the research is ongoing, but also the government structures. If at all there's any question, be it political or administrative, they would expect a community advisory board member to be in position to engage both the government structures, the community, and also those researched. However, you may find that when it comes to discussing with the community and they get to know the type of research, the objectives of the research, you may find that for them, they only identify those individuals they believe will help them move along at the same pace and understanding, like the researchers, explain any problems that they are faced with, and they may not have any, they don't think that there's a need to link that to any political structure. However, the protocol team members might feel that as part of the community advisory board, there's a need not only to engage those that are going to be researched, the communities, but also to inform the government structure. So there's a need to have a mix. And that is why sometimes the protocol team members come on board and engage the communities to accept some particular cadre of being a member on the community advisory board. So there is that element of, as a challenge, the mix of the community advisory board, because some security apparatus, they want to know everything that is ongoing in some of our communities. So there's a need to have somebody maybe at the community advisory board who can stand in and help fill that gap. I submit.
Thank you very much. Jane, I've got a question here that I think I'm going to ask you first, if that's okay.
Sure.
The question is from Charles Luanga, and he has said that they've been experiencing challenges in carrying out research in COVID. And as a result, they've decided to do telephone interviews to collect data from respondents. Now, the question asked here is, how do you guarantee consent? How do ethics bodies ensure that consent can be adequately administered? I'm asking you, Jane, I guess because of the sort of patient protection issue. Do you have any thoughts about the use in the COVID African context of the use of telephone-based research interviews?
Okay, thank you for that question. Indeed, issues of consent have come up as a major challenge in the setting of the COVID-19 pandemic, not only regarding remote interview techniques, but also in the setting where there is a severely sick patient or unconscious patient, where you do not have a caretaker in the highly infectious treatment units that we are working in or collecting research in. But essentially, a lot of the consent challenges have been reviewed on a case-by-case basis with the ethics committees. And there have been different tiers of requirement for consent depending on the risk related to a particular study. For example, if you're collecting basic information remotely by phone calls, the ethics committees have provision for obtaining a verbal consent. So it is really between the different research teams and the ethics committees to decide what is acceptable for the different settings and for the different research groups in terms of what would be accepted as an acceptable or documented consent received. So do you want a recording of consent provided within the context of that phone call, or will it just be a tick to say, yes, at the start of this interview, the patient verbally agreed to provide consent? So there are different aspects that have been put in place to ensure that different kinds of research actually do take place, and to ensure that within the different approaches or regulations, some of the research can still go on with modifications to the approach of obtaining consent. So there is provision for that.
Thank you. Julius, I wonder if I may ask you a question, and this is something I think we will all have some experience of in our working lives. But this is a question. This is a question from Bunu Umara, and the question is, how can one carry out effective safety measures in a toxic workplace culture, particularly the person you are reporting to is behaving unethically? Now, these are, as I say, challenging questions, and I've certainly, in my life come across these kinds of problems. How, because one of the things I think about you know, ethics, and one of the things that came up in our Nuffield working project was ethics is also very personal. It's also about how people relate to each other. And if you can't have a positive professional relationship with somebody, in a sense, the regulatory structures almost, not quite, but almost fall away, because you're seeing someone behaving unethically and you can't intervene. You know, what do you do? Tricky question, Julius, I appreciate, but I'd be very interested in your thoughts.
Thank you very much. Yes, like you said, we have worked sometimes in this kind of conditions. I could bring up one example. I had a colleague of mine, we were working together, and during one of the outbreaks, and originally this colleague of mine was working with the armed forces. So he had that idea of being more enforceful than probably more cooperative with the patients. And of course, asking consent, sometimes a person thinks, it takes time before one may say, oh, okay, let me go along with this or not. And of course, with him, he didn't have that kind of patience. When he says, well, we would like to get a blood sample from you, and for this and that and that, his idea was like, you have to say yes. If you're not saying yes, for him, he has to get a blood sample from you. It's like, why? We have come to do this and we want your blood sample, we have to take it. So it was like, he was more forceful. And of course, if you have like several other people waiting outside, and they feel like inside the room where the samples are being taken, there is a lot of force being used, then if you look out of the window, you will see them walking away. So that makes the situation very difficult. You have to go back, because normally you have talked to these people, you have tried to convince them, you have tried to tell them what it is. And then, of course, you require each one's self-consent. And you're telling this person to say, okay, here is the form that you have to sign to show that you've really consented. And one is asking a few or three more questions, and somebody is impatient with that kind of patient, then it makes it very, very difficult, even for the others. Of course, when he goes out, he's going to tell them that, you know, they are using force inside there. So, so those kind of situations really do. And if this is, say, your boss or the head of the program, you can hardly tell him that, you know, what you're doing is not going to assist us. It is actually going to be a problem for us, and we may not be allowed here any other time. They may chase us away. We have worked in situations where the community is either under siege, or there are some rebel activities within the areas, and if you're not very good with these people, you can get waylaid, and of course it becomes very difficult. One time we had a study, and among the study participants there was a teacher who was very good at asking so many difficult questions, and he was like all the time whom the other members of the group would use either to accept or not to accept, and you have to be very patient with this person, because he would ask very many questions and was apparently being looked at as the opinion leader. If he accepts, then the others would accept. So you have to be very patient with this person. And so there are sometimes when it is very, very difficult, because this person could report to the authorities, say the administrators of the area, that this group, this and this is what is happening. Although they came to do work with us, but they are not cooperating with us. So those kind of situations happen, but it all depends on how you handle them. So that handling of your participants is very, very important. And of course, every time you go to them, you have to ask for their consent. Even if it is the same group you are approaching over and over again, you all the time have to ask for their consent. Thank you, Opa.
Thank you very much. Very incredibly kind of vivid account of the sort of the challenges involved here. Katherine, I think I've got a question that's directed at you from John Hongo. Question to Katherine: and not just to Katherine in some ways, but were there any ethical challenges using, or were you aware of the ethical issues emerging around the use of multiple languages for the use of consent and consent forms, where you're trying to recruit participants into studies? Is that an issue you have any particular thoughts about?
It was certainly, I mean, it certainly emerged as an issue, I think, particularly in examples of where consent processes hadn't gone well. And the obvious examples are either using written forms in a language that is not familiar, or where indeed actually written materials are not the most appropriate form of communication. So, I mean, I wouldn't say we didn't make any specific recommendations about the use of languages, other than in the sense of, at the heart of a consent practice, it's not about what the form looks like, it's about what have researchers done to make sure that people are informed enough to make a choice that's free, and then that's been documented in an appropriate way. I think Jane touched on that, talking about, in some kinds of phone call, a yes will be sufficient. In other cases, it might be appropriate to record the phone call, and so on. But I think, again, outside emergencies, because consent is so important, I think we've surrounded it by a set of processes to achieve it that then almost become more important than the consent itself. We have to remind ourselves that a signature on a consent form just shows someone can write their name. What's important is what lies behind that signature if you're seeking written consent. But in some cases, verbal consent recorded in some way may be much, much more appropriate. But actually, before all that, it's how information is shared. And if it's not being shared in a language that people understand, then I think you've fallen at the first hurdle of a meaningful consent process. If someone were to ask me either to agree verbally or to sign something related to a language I don't understand, we're not talking about consent at all. We're talking about just trying to process people through a system, and that's not ethical consent.
Thanks, Katherine. I've got a question here, possibly a question for Tom, and it's from Elizabeth Bachili, and she is asking, how do we engage, I guess, multiple duty bearers, in relation to research, such as governments, government health workers, I assume also funders, international funders? How can in this context, this kind of COVID outbreak kind of context, how can how can duty bearers be properly engaged as part of this research process? Any thoughts on that, Tom?
Well, if at all you are to contextualize it in communities like where we work, there are both government and workers, health workers, who might be having different structures of management and administration, but who are all engaged in one way or another with the epidemic that has brought the research team in the community or the data source center. And one thing that we realize is that how you engage these cadres might be very different from how you engage the potential study participants. Usually there's what we call a protocol summary whereby, because whatever you do, whatever you engage in a form of research, ultimately, you will continue informing these structures to better the case management, to better the pandemic management. So right from the word go, you need to plan how to engage with not only the community, all the source of study participants, but also those that might be engaged when it comes to discussing guidelines or policy that will be taken on by all communities, not only the community that is researched on. So right at the starting point, you may have guidelines how you are going to involve the community, but it's best also to identify the process of making health better. Who are those stakeholders? And have a guiding principle, the entry point, the engagement, and ultimately how you can work together in order to better all whatever you are doing, if at all you are still in the communities carrying out the research, or even planning for the post-research era. Thank you.
Thank you very much, Tom. I've got a question that I'm going to, hopefully, I'd like to ask both Jane and Julius, but I'm going to start with Jane. It's kind of piggybacked on a question by Oka Obono. And the question says, in Uganda, during the Ebola outbreak, he said, I found that the communities such as in Nyanswiga had views of the outbreak and its causes that were different from those of the local health authorities. And that was one source of mutual suspicion between the community and the authorities. Jane, if I could start with you possibly, I wonder, because one issue that comes up again and again and again, it's directly linked to this question, is the question of misinformation. This incredibly disruptive and damaging circulation of misinformation around maybe the outbreak or the motives of the people, the health professionals who are intervening, the motives of external or local researchers, et cetera, et cetera. I think it's a crucial problem. We've seen this globalize during COVID. I mean, here in the UK, there's all kinds of mad conspiracy theories in circulation about COVID, that it was Bill Gates who did it, or, you know, it's aliens, or, you know, all kinds of nonsense. I wondered, Jane, if you have any thoughts about how you know, health professionals, researchers, those committed to responding to infectious disease outbreaks can tackle this kind of thing.
Okay. Thanks for that question. If you may permit, I would just like to supplement on the previous question that was mentioned about the duty of the office bearers or the current individuals we find. Yeah, I think they're quite key in what we do. I'll give an example of a research we are conducting right now, looking at the burden of malaria among patients presenting with COVID-19. And we are working across 8 facilities across the country. We sat down and met all the members of the health facilities and we were working with, and the decision was that they would not permit the research team to move from facility to facility, collecting blood samples and collecting data. And the agreement was at that point was we co-opted all the health facility members as research staff. So instead of going to a hospital and entering the high dependency area or the highly infectious areas, the health facility staff actually did implement all aspects of the research on behalf of the research team. So depending on the settings where we work, these office bearers or these government health workers are a key component, and they actually support research quite in a big way. So back to the question that you mentioned, I think it's quite key to ensure that the views at the community level are tracked and monitored. There are different research groups that handle this differently, but a lot of research groups use anthropologists and social scientists to ensure that they keep a pulse on the communication and the noise at the community level. And this is quite important because if you do have a way of tracking this information at the community level, you have the opportunity to address address these issues earlier before they escalate into a situation where they cannot communicate with you. So it's ensuring that you have a good social sciences component, or you have key anthropologists that are involved, but also it still tags on to what is your community engagement plan? How are you keeping track of the pulse of the noise in the community, and how effectively are you tracking this information coming up? Is it a newspaper article? Is it a journalist that may have a wrong perception that is then escalating this situation? So it's really keeping a track on the noise, or keeping a track on the emerging issues coming up at the community level, and ensuring that there is a very active key feedback loop that addresses these concerns objectively and also understands the cause of these concerns and then tackles it from the root. So it's really having a very active community engagement plan, but also the necessary skills to track this noise and keep a pulse on what's coming up. Yeah.
Marvelous. Thank you very much. I'm going to ask Julius if he wouldn't mind responding as well. But just to say, I notice in the chat bar that Sunday has a hand up. If you'd like to speak, then after Julius has made his contribution, we'll come to you, and our wonderful team behind the scenes will unmute you. So if you do want to speak, Sunday will come to you after Julius has mentioned a few words about this really tricky problem of disinformation and misinformation.
Thank you very much. The problem of misinformation is actually, like all epidemics, in our situations always come with a lot of misinformation. Each epidemic may come with a different kind of misinformation as to what is the cause, or even if they know the cause, why nothing is being done, or whatever is being done. Most often in our situations today in Uganda, it brings in a lot to do with the politics, and politics plays a very big role. Even if the people who are involved know exactly what it is, they will turn it either against government, or government to turn it against the opposition, making it very difficult for the health workers, making it difficult for the responders to provide very right information. However, what is important is that the responders, the health workers, should provide as much information, as much true information as possible. They should try to explain in honest terms what are the causes, why is the response is the way it is, even if there are shortages in the way, for example, there may be lack of treatment, or the treatment may not be enough for everybody at a particular time. All these should be explained honestly, because these are going to be used either by the government or the opposition to say that is why this and that is happening. So all channels of communication should be engaged, and the responders should try as much as possible to be friendly. And of course, the researchers have got to work with the responders to be able to explain. They should get opinion leaders to be part of their group, such that when they explain, they really explain and understand very well. During this particular COVID situation, I have talked to some politicians. They know very well, they understand very well, but they know that if they go and talk exactly what you've told them, then it will be like they are supporting government. So they would rather not say anything than actually support you to provide the right information. So you have to involve as many people in the community as possible for you to be able to provide the right information, such that as much misinformation is done away with, so that everybody gets to know what the right information is. Thank you.
Thank you very much. Could I just ask then if Sunday would like to speak, if we could kindly unmute and perhaps Sunday can come in. I have a symbol next to your hand, Sunday, suggesting that now you're unmuted now. Please do come in.
Okay, can you hear me now?
Yes, very clearly.
Okay, good morning, everyone. It's actually morning from this side of the world. Okay, so my question is directly to Jen. I appreciate your presentation, but a little bit concerned as a sociologist in respect to options of interview. You made mention of a full telephone or a visual interview. So against the usual, the traditional face-to-face interaction. So I'm a little bit concerned looking at the rich information that could be generated by face-to-face interaction, perhaps body language, the setting and what have you, which makes the analysis of whatever this thing you're looking at. So I'm a little bit concerned because I quite understand the changes that have occurred over time, the new normal, but I'm just concerned that don't you think that it will a kind of reduce the richness of the information that we are looking at?
Thank you very much, Sunday. Jane, can I ask you to respond? That's a question really about the impact of telephone interviewing, I guess, on the richness of the kind of information. What's lost by telephone interviewing, as it were?
Well, I mean, I think we've had different discussions regarding the shift to more remote methods of data collection. And I guess the changes really depend on what stage of every epidemic or pandemic we are in and the different risk factors that are faced at these different stages, but also it depends on the safety measures that can be instituted. So different research groups respond differently depending on their circumstances. So at the height of the epidemic, when there was lockdown and there was really no meaningful movement, there was a lot of shift to the remote methods of collecting data, either the telephone conversations or an electronic CRF that was then sent to participants to complete. However, I think the key message here is ensuring participant safety. If you think you need the focus group discussions or the more qualitative observatory methods of data collection, you need to ensure that within that context, the participants are safe. Everyone has a mask, there is sufficient social distancing. Even at the ethics committee or the regulatory level in the countries, you need to provide a risk management plan for the research activities that you're proposing. So essentially, it's not a prescription that this should change completely to remote, but it is the context within which you find yourself. If according to your risk management plan, you can safely do face-to-face interviews, then that is a protocol that the ethics committee or the regulatory agency in the country will need to approve. But the ultimate objective, are the participants safe, are the staff members safe? So it's not really a prescription, but it's really the different decisions that are taken depending on the different risk measures that are available.
Thank you, Jane.
Over.
Thank you, Jane. Thank you very much indeed. Listen, I'm very conscious of time. I'm aware that there are many more questions that people would like to ask, but we do have another opportunity to ask questions later on. So if people have, if people have burning questions, if they could hold on to them. But I think what we may do is to take two more quick live questions, one from Tobago and one from Charles, and then we will close for lunch. So if I could possibly ask for the questions to be brief and to the point, and if you could also let us know to whom you would like the question addressed. So Tobago, if I could ask you first.
Can you hear me?
You're quite faint, but we can hear you.
Oh, okay. Thank you very much. It's Debo Homore in Johannesburg. My question is around consent and gender expressions. So what is our understanding or what are the ethical challenges when collecting data or getting consent in regards to gender expressions? Because there is an outcry that when we collect data, we would just say this is a male or a female and we exclude other gender expressions. Thank you.
Thank you. Anyone, Tobogo, is there anyone in particular you'd like to address that tricky question to, so that I don't have to point to somebody myself? No? Okay. Well, I think, I mean, I'm going to, for me, it seems Jane and Tom are both well poised to answer this question. Tom from a regulatory perspective, Jane from a kind of patient participation perspective. So I'll go to Tom. Tom, your very brief thoughts, if I may, first on this issue around gender identity or non-binary, people who may not identify as binary. Do you have any thoughts about, from a regulatory perspective?
I'll have to be sincere. Here in Uganda, we have not been guided how to render services to protocol team members who have the plans of engaging the non-binary that we know of. However, I would like to say that if at all you form part of the species called human being, we have guidelines that are used when it comes to research amongst human participants. Now, when it comes to gender expression, I know that we receive, say, informed consent forms labeled for the male, labeled for the female. And if at all there's a need where, if at all the protocol team member is to submit a consent which is other than those two, I believe would involve the National Regulatory Authority to guide us on how best to review, accommodate, and follow up. As of now, I don't know whether our colleagues in Uganda can help come on board. We are not guided how to receive, accommodate, review, and follow up such research indoors.
Thank you very much. Jane, any very quick thoughts?
No, I think Tom answers for the same set in Uganda. At the consent level, there are none, but I know that at the data collection level, there are different groups that provide an option for either other or a choice not to respond to that particular gender question. But at the consenting level, Tom really presents the picture in Uganda.
Lovely. Thank you very much indeed. Now, if I may come on, and finally, Charles, a question from you, please. If you could let us know if there is anybody in particular you'd like to address it to, please do let us know. So Charles, over to you.
Hello, Julian, can you hear me?
I can hear you loud and clear, Charles. Go ahead.
All right, so thank you so much, Julian and the team. And once again, I would wish to come back to Jane and a bit of Tom Lutalo, because the same question that I asked before, and I think somebody else also asked the same, is on the telephone interview. The reason is we are actually about to do some research, but because of this COVID, we are resorting to telephone interviews. And of course, now telephone consenting process. And I would have wished maybe this maybe a suggestion to this team that maybe in the next webinar, you might want to have a team that is beyond just Uganda, so that maybe when it comes to ethical considerations, then different countries are represented, because I keep on hearing that this refers to Uganda. This is what we do in Uganda. So it's something to consider, that if somebody is asking a question about other countries like Kenya, I'm in Kenya, then how do you go about this? So for Tom, maybe if you were to, approve a protocol that is concerning telephone interviews and telephone consenting. So is there like any catching word or catching phrase that you can use in your protocol that can, receive approval at the ethical approving body? I want to do a telephone consenting. So how do I write that in my protocol so that it can receive approval at the ethics body? Thank you.
I know that this has evolved actually from the first time we were introduced to the telephone interview design to now. This has evolved through a number of interactions. But one thing that we receive as a research ethics committee for those that have plans of using the telephone, there's this question of confirming that the person you are talking to is actually the person you are supposed to interview. So there are some screening questions that we expect when you are engaging this study participant using a telephone. However, there is some protocols that have been approved that after the screening questions, they ask for permission, consent, okay, to record from the participant, to record the consenting process. Those ones we've also reviewed, whereby the tool you are using to engage with these study participants can be used to record that engagement. And that is something that we've reviewed and approved. Another method that has been submitted is, if at all, after the screening and then the consenting process, is there a third party who has listened in and they ask the participant, they introduce that third party who might, in the interim, sign that he was a witness, in the interim, sign that he or she was a witness. And then a third option I remember was, even if you had to use either of the model, if at all you had to submit a risk management plan, you may follow up these particular study participants by engaging them at a distance, using the protection that you can come up with for them to go ahead and confirm that they accepted to be interviewed, and they sign on a paper, which you can also keep at a later stage, because these are evolving times, and all such designs, we need to accept that this is something that that can be acceptable. I submit.
Yeah, maybe let me make a comment.
Bernard, please do come in.
I think you raised a pertinent issue that the panel probably is quite Ugandan, but we thought that, especially for ethics, things don't really vary very much, little variations by country. But maybe I'll ask the TGHN team to flag the link for a webinar next week, which is organized by Pandora and TESA. Pandora is also a network funded by EDCTP, is responding to epidemics as well. And TESA is the equivalent of ESCCR for Southern Africa. And it's particularly going to be focused on ethics in outbreaks, ethics of research during outbreaks. And I think it will be a bit more, it will be broader and deeper. This was trying to put together different aspects of research, right from conceiving the idea to the challenges of implementing this idea to the ethics. So we were not really focused on ethics per se, never mind that the conversation seems to have gone down towards more of ethics. So Charles, maybe apologies for that, not including many people from other countries. Sometimes it's difficult to find people that can find time to speak. But next week, there's definitely one that would be richer in terms of representativeness, because I know we have a Ugandan speaking in there. We have people from Southern Africa speaking and people from Central Africa speaking. So that would be very helpful. Thank you.
Thank you. If I could just ask whether Katherine or Julius, whether you have any final comments before we draw to, before we break for lunch. If I could start with Julius. Jane, you also want to say something?
Yes, I just wanted to supplement what Tom mentioned about the verbal consent. I think in addition to the verification processes that the ethics committees go through, I think in the research protocol submitted, it's important to indicate why the verbal consent is the best option. The other forms of getting consent may not be applicable for the session, and just to kind of describe why that particular protocol is opting for the verbal versus the standard forms of consent, in addition to the other things that the ethics committee will look at. Yeah, that was my additional supplement. Thank you.
Thank you very much. Julius, any final thoughts from you?
Nothing really in particular. All I wanted to say is that I am very grateful that I was given the opportunity to be part of this great team. And I think the sessions have been very, very good sessions, and the discussions have been very good. And we thank you, Julian and Bernard, for being very good moderators. And of course, my co-panelists, I would like to thank you very much, and all the attendees. Thank you very much. I believe we have had a very good sessions, and look forward to the next sessions. Thank you very much.
Thanks, Julius. Katherine, any final thoughts from you?
I think just briefly, likewise, it's been a real privilege to be part of this panel. Thank you very much. And I think just reflecting back on the point about how, while it wasn't set out to be an ethics session, as it were, we've talked an awful lot about ethics. I'm obviously delighted that that's been the outcome. And I think it also illustrates this idea that ethics does permeate everything we do. Ethical review is one point when we have important regulatory structures that support people in thinking through ethical challenges and make sure they've been thought about. But that's only a little bit of the picture. Actually, as researchers, as funders, as governments, the values that underpin what we do actually affects that experience on the ground of researchers and participants. I think we have to keep chipping away at all those different levels to achieve that. Thank you. Thank you again for including me.
Thanks, Katherine. And we are now going to break for a lunch. For me, it's probably just about breakfast, but we'll take a relatively short break now. The team will put a timer up on the screen so we know when we should return to our screen. So thank you all very much. Wonderful, wonderful panelists. Thank you. Great questions, great attendees. Thoroughly enjoyable session. Thank you very much indeed.
You're all welcome to the afternoon session. We have two more speakers, and then we will have the final Q&A session. So I'll be chairing this session, and then we'll welcome Julian to moderate the Q&A session after the two speakers. So this afternoon, we have two speakers. One will be Joseph Boni, who is from Ghana, and he will be telling us the African story of conducting a multinational research program in Africa during an epidemic, which is the CCP protocol. And then we'll have Dr. Bruce Kirenga from the Lung Institute at Makerere University, who will be telling us about how to publish our research findings and how to disseminate our findings during an epidemic. Those will be two. So right now, I don't want to waste more time. I want to welcome Boni. Now, Boni is an emergency medicine specialist from Ghana, and is currently working with John Amoas on the clinical characterization of COVID-19 protocol, which is funded by the Wellcome Trust in the UK. And this protocol is being implemented across several countries in Africa. Boni, you are welcome to take us through the African story. Thank you.
All right, thank you very much. And thank you all for joining this workshop, and welcome to the second part of the workshop. I can see we still have a lot of participants online. So My name is Dr. Joe Boni. I'm an emergency medicine specialist at the Konfo-Anokye Teaching Hospital in Kumasi, Ghana. And I also work as a research fellow with the Global Health and Infectious Disease Research Group at the Kumasi Center for Collaborative Research. One of my activities there is helping to run the clinical characterization protocol in Ghana and my vast experience in what is happening across the African countries. And I'm very happy to share this with us today. So we're talking about ALERRT, the clinical characterization protocol, a multinational research response in a global health emergency, looking at the African story and how it has gone in the African continent. I already introduced myself. I work with Konfo-Anokye Teaching Hospital. So ALERRT is a consortium of organizations, so 21 partner organizations from 13 countries, 9 in Africa and 4 in Europe. And this shows the list of the ALERRT consortium, the partners in the ALERRT consortium. And here you can see the countries where they come from. So at Ghana, it's run at KCCR under the Global Health and Infectious Disease Group. So what is clinical characterization protocol? The clinical characterization protocol is designed for any severe and potential acute infection in the public health interest. The idea of this, when it was designed initially, was even before the onset of COVID-19. But with the onset of COVID-19, it has been rapidly adopted for COVID-19. And it's a standardized protocol that enables data and biological samples to be collected rapidly in a globalized, harmonized manner. So take, for instance, these silos represent information that people are gathering. And if each country or in some conditions, some institutions, even per country, are collecting information about a certain disease in separate instances. So this does not give you a chance for you to collaborate. The idea of the clinical characterization protocol and why it is important is that it allows you to link all of these institutions, the information from this, making sure that it is harmonized in a very specific manner. And not only that, but to allow for it to give a common output. So comparable results, a large data set, allowing you to generalize your information. And this increases the impact of the study rather than sticking to individual data being collected, which is not comparable, which is not standardized. So with this, ALERRT looked at the ISARIC protocol. The ISARIC is the International Severe Acute Respiratory and Emerging Infection Consortium, which developed the clinical characterization protocol for COVID-19. And this protocol was endorsed by WHO. But looking at the protocol, there had to be some changes in order to make it Africa ready, make it adaptable for it to be used in countries or across the continent, and even among countries, there were still some adaptations. So although the study was with ALERRT, there was a lot of collaboration with WHO Afro, WHO CDC, and other networks, not to reinvent the wheel, but to hinge on the networks that are already available in order to make this protocol a success. So some of the changes that were made across the African countries were like in view of the ethics and then the consent process. The original form had the fact that people had to sign this, but we included the fact that people could tamper it. And then the risk of infection or the form being a format, the idea was to have a picture of the consent form. And in some cases, people have discussed the use of voice recordings of them saying that they approved the study or a video recording and so on. The details of the data collector was also added to the study. This allowed us to be able to find who collected the data at what point and allow for accountability and easy correction of data. For employment, we realized that we had a lot of participants or people in these countries who had the place that they spend most of their time, which might not be their formal professional occupation. So we provide access for people to put two data in there: what your formal profession is and what your occupation is. Then for the comorbidities and risk factors, we expanded this and looked at the details of alcohol consumption or smoking to find out whether there was any correlation with this, increased the details of imaging. And then, as was discussed earlier, we realized that the mental assessment seemed to be missing in the management of COVID-19. And we used this to bring the attention of the providers to mental assessments using the Kessler psychological distress scale, which would measure the need for a psychological assessment or not. A lot of the countries did not have or do not have an electronic medical records widely available. And in the introduction of a form that would allow people to collect data, the thoughts were, instead of just providing data collection as this tool, why not provide this as an EMR of a sort? And this was well received among some countries where identifiable data and doctors and nurses' notes were added as separate forms onto the electronic version of the data collection tool on REDCap. So now not only did this serve as a regularized tool, which was very ordered and very standard, but also served as an EMR that could be used in facilities where an EMR was not available. So this shows examples of the forms that were adapted, the first couple of pages showing the how the form is if it's in a paper format. And then this is how it looked like on REDCap. We designed these forms, so all of these forms are available on REDCap, but this showed how the forms should be filled. So forms that should be filled on day one, forms that should be completed every day. So these were the daily signs and symptoms, the daily vital records, if he was in ICU, daily ICU records, daily medications, daily complications that were present. And then what was not required, and this is what we designed for people that wanted to use this as an EMR, was doctor's notes, which provided free text for both doctors and nurses to be able to document this. And then your laboratory results, including the Kessler psychological distress scale, and then the overall outcome. So outcome, overall medications, and supportive care. The study was implemented in a very standard manner, ensuring that the case management of each country was well informed about the implementation of the CCP. This allowed you to be able to navigate the system without having to deal with the backlash of the politics, which I'll talk more about in the challenges. Then have a coordination, and the coordination will deal with regular meetings, trainings, are the equipment available, is the data being collected, as long as a cloud management team who would ensure that data can be collected from multiple sites, but can be collated onto a REDCap server and data can be intact. Our data capturing tools were tablets and laptops, and then you also had your health facilities. And see the arrows going in between all of these, showing the coordination between your health facilities, cloud management coordination, and the COVID-19 management team in your country. So in realism, in the African continent, we have 5 countries that are already running the CCP, the Clinical Characterization Protocol. Senegal has reached 260 participants and is looking at commencing a 1 month, 3 months, and 6 months post-discharge study. Cameroon has obtained ethical clearance and is going ahead to do their trainings for data entry and recruitment to start in December. Ghana received ethical clearance far ahead of time and has already entered over 1,000 records so far and developed a dynamic dashboard which is fully operational, and you're able to see the data being graphed as you enter it, and I'll show this in a few slides ahead. And 2 sites are open, and the plan is for them to start data entry soon. Both Kenya and Uganda have the database set up and are waiting for ethical clearance in order to start data entry. An example from Ghana's setup shows that 2 centers that are set up are given us different numbers of data, and in a new site, St. Michael's Hospital in Jachapramso and Kintampo Research Center, which should be starting up pretty soon. If we talk about the challenges, we have a lot of challenges in implementing such a study in the continent, and this includes ethical clearance delays, implementation and training, being able to get onto site, the politics, both national politics and inter-hospital politics, the monitoring of the data, ensuring that the data you have is actually accurate and correct, resource mobilization, and collaboration and resource mobilization, tools and technologies, quick and relevant outputs, and then a race against time. Looking at a quick practical solutions to this, so using a pre-designed protocol. So using the ALERRT protocol made it really easy for you to adapt the protocol and then use the adapted protocol to submit to ethics. This gave you more leverage to be able to get through ethics a little quicker, as this is a pre-designed protocol that you're adapting. And also discussion with the ethical committees for an expedited review. For collaboration and resource mobilization, the advantage of having various institutions coming together to collaborate, to work on this, is a really big advantage. This allows you to be able to bring resources from various institutions together to be able to get this done, and to use the local staff of the institution. If they agree to be part of the study, then they will become either the research assistants, the monitors of the study, the site PIs, or the site coordinators for the study. And then applying for collaborative funding. Don't work on it alone, but have a consortium that would come together and apply for funding. And this allows you to be able to get a bigger number of people contributing funds to the study, or a bigger organization contributing funds to a collaborative rather than to one individual or one organization. And most importantly, use science as an incentive and not money. The idea would for people to be able to know that their efforts will collaborate into advancements in knowledge, and in this case, advancements in treatment and care, rather than the money that they will make from this. For the implementation and training, it really is about being honest and open. So open discussions with the leaders on the site on the implementation, and discussing what will work with their institutions. Training on site, being at the site and training and understanding the challenges that the site have, and using the local leaders at the site as the site's PIs. For your technology and tools.
Joseph, you have 5 minutes.
Yes, thank you very much. The use of offline options if possible, if internet is not available readily. And then which apps will work for you? Are you going to use a complex app or use RedCap? Will the RedCap work for you on a tablet, or will it work better on a PC? And from my experience, due to the load of the database, the RedCap on the tablet usually has problems syncing, and we are gradually moving to using RedCap on the computer or using a web interface. And then using technology to keep your devices safe. If you're using tablets, have a tracking system to make sure that your devices that you're using are not lost in the course of this. The politics of the study, keeping all the authorities involved at the start of the study with regular updates to all the political leaders, both at institutions and also at the national level, and also be very mindful of the local politics. Have implementation papers available to give it out, and then the dynamic dashboard, and then media output, regular media engagement, and sometimes you can put some messages on what is happening with the research on social media. Set up ways to monitor the data that is coming in, and regular retraining and physical reviews, and it's always a race against time. Use the preset protocols, work fast, work collaboratively, and be ready. This picture shows the dynamic dashboard that we are using in Ghana, and this tool is available for all the other countries that will be at the stage where they can show this. And this shows you the data as it's being entered. So there's a dynamic dashboard, and as the data is entered, this can be seen by the health authorities, and they can use this to make changes and policies in real time and not wait for the entire study to be completed. In conclusion, we look at the global health emergencies will happen, and as we've seen with COVID-19, we might have more coming in, and research and quick output of the research will help improve healthcare and provide treatment and vaccines available. Thank you very much.
Thank you, Joseph, for that quick brief about the CCP. We shall be getting questions later. I think we've seen that it's 5 countries involved. Some have started collecting data, others haven't. The delays we talked about, ethical approvals, and the political challenges abound. But probably Joseph will be able to answer the questions that follow. Our next presenter is Dr. Bruce Kirenga, who is going to talk about publication and dissemination of research findings in epidemics. Bruce is the Chief Research Scientist and Director of Makerere University Lung Institute and a Senior Lecturer at the Department of Medicine in Makerere University. He's a clinician with a Master's in Medicine from Makerere University and a PhD in Medical Sciences from the University of Groningen. Bruce, you're welcome to share your experiences.
Good afternoon. So I'm going to make an effort to present about dissemination and the publication of research findings during epidemics. This is a very interesting topic, which I think I cannot say I'm an authority on it, but I tried to look around to see the information that is available, but also our personal experiences with disseminating COVID-19 research findings. So most of this is going to relate to COVID-19, but I guess it applies to other pandemics. So as a word of introduction, the COVID-19 has been with us for now over 10 months, and this disease has disrupted nearly every aspect of normal life across the globe. It can also be expected that research, its fears, could not have been spared. And since morning, we've been listening to people talking about different aspects of research having been affected by COVID-19. In terms of dissemination, we have seen a lot of changes to how research information is disseminated, and I will go through this. There are advantages and disadvantages of these changes, and we need to learn from what we have observed for the future. Dissemination is simply...
Sorry to interrupt you. Your slide's a bit small at the moment. If you go to display settings at the top of your screen, you can see show taskbar, display settings, and end slideshow. Can you see that at all? There should be a section that says display settings. Yep. And then if you switch there, that should perfect. That's it.
Okay.
Great. Thanks. Sorry to interrupt.
So dissemination can be simply defined as the process of sharing research findings with what you consider to be your stakeholders and wider audiences, both scientific and non-scientific. I've picked a definition from the NIHR of the UK, where they define dissemination as getting the findings of your research to the people who can make use of them. I like this one from many that I found because it's just getting the findings to people who will use them. So if people are not going to use your research, they are going to make it gather shelf dust or digital dust. There's no need to give them your research findings. There are peculiarities of pandemics. In pandemics, dissemination should not be considered as business as usual, where we write our articles, have institutional review and friends review, peer review, then publish research findings. In pandemics, we must understand that the pandemic itself triggers a lot of negative feelings. Everyone is stressed and anxious for information. If you take the example of COVID, everyone, politicians, scientists,
farmers, everyone was looking for information. And psychologically, people want to use this information to strengthen themselves. So if you keep away information from them, with the little information you've got from the research findings, you increase the problem. And when people are anxious, they can be prone to misconceptions. So theoretically or psychologically, dissemination can be a learned response where in uncertain circumstances, people increase their dissemination activities. For example, in pandemics, there are three uncertainties. The first one is what is known about this disease. For example, when COVID came in January, no one knew what it was. How can it be prevented and how will it be treated? These uncertainties create the demand for information that requires that as scientists, we also change the way we provide information to the people who need it, who can make use of them. Now, traditionally, we know that dissemination is made of the 3 Ps: posters, presentations, and papers. However, of recent, we have seen many other forms coming in. For example, research findings could be disseminated through social media, through print media, through press conferences, and all sorts of channels that deliver information. We are going to handle each of these one by one and see how it has worked out during this epidemic. For example, if you start with journals, the traditional way of publication has been changed during this pandemic. For example, several high-ranking journals have come together to make sure that information about the COVID-19 epidemic is rapidly available. These journals could include journals like The Lancet, the New England Journal of Medicine, and others. And right now, it is required that if you write any paper on this pandemic, that paper will be made available immediately. On the right side, you can see this is an email that we got when we submitted our paper to PROS 1. They said, 1, they will share it with WHO. 2, they recommended that we send it to MedReview for publication, and it was published without any form of peer review apart from internal author peer review and institution. When you look at going forward with the push of information during pandemics, this is a press release from the Wellcome Trust, January 2020. They said that we call on all researchers, journals, and funders to ensure that research findings and data relevant to this outbreak is shared rapidly and openly to inform public health. And they had a number of commitments, including making sure that all peer-reviewed research publications relevant to the outbreak are made immediately open access. That research findings to the outbreak are shared immediately with WHO and other public health organizations. And then they went on to say the findings should be made available through preprint servers before journal publication. And then researchers need to conduct interim analysis and share results before the final. And we have seen all this happening. For example, when you look at the antiviral remdesivir, there was an initial report and a final report. Then authors are clear that data and people are shared ahead of submission will not affect the publication of the articles. Now, this is a graphical representation of what is happening now in the field of dissemination in a pandemic time, proposed by Fuller CD. You can see there is pre-registration of the research if you can. So you publish your research plan. Then when you have the data, you put it in the preprint. Then you go for peer review, prioritize open access, deposit publications in accessible institutional websites, and have what they are calling as a data descriptor. So with this, the whole aim is to make sure that findings are available to help in the response to the pandemic. Now, this kind of approach to journal publication or scientific publication has advantages. The first one is that the results are quick and available, like I've already said, but there are disadvantages that data that is not well curated is published. However, also this data that is not well curated can be dangerous to clinical science. For example, hurriedly published data on preprints causes panic within the clinical trial community,
where some trials have even been stopped. Government have rushed to make guidelines based on data that is not well curated. And we have also seen in some of our trials, patients saying, no, we saw on Facebook, this drug doesn't work. Why do you want to give it to me? So these are the challenges. And coming to the issue of analyzed publications, you know this scenario in the Lancet and in the New England Journal, the two biggest journals that we have, where on May 1st and May 22nd, these two journals published an article, which article was actually later found known to be correct because the way they used the data, using data mining was not correct. And the article ended up being retracted by the Lancet and the New England Journal. So you can see this can be such a big issue to these big journal houses. This is not to mention the smaller ones. Therefore, again, Fuller CD, they have proposed this schema, which I found to be very important, that you must have a research plan, even if it is an emergency. You must register that plan. You must deposit your results in a preprint, but still follow up to have a full manuscript and a journal publication, preferably in an open access journal. But most importantly, the data must be shared. Now, coming to this data sharing is one of the ways to expand our knowledge during pandemics. If you share this data, I can analyze it in any way I want and come to a conclusion, both local and international. And these guidelines, called the FAIR guidelines, have been published to make sure that when you deposit the data, it can be used by your colleagues. And they use the acronym FAIR, which means the data must be findable, accessible, interoperable, and reusable. So this is also something that has come out very strongly in this pandemic, that we should all endeavor to make sure that we have shared the data that we have to aid in the pandemic. So it's some form of dissemination in a way. This brings me to social media, that social media has now caught up with us. It has not a traditional of publishing research findings, but you'll find that many journals, organizations, news channels, big ones, including BBC, CNN, they all have social media pages where they deposit their findings or reports. Also, many executives, scientists now operate social media pages where they connect with people. And many researchers are now identifying the advantages of using social media. In terms of clinical science, social media can actually also be a way of CPD or CME, where clinicians keep updating themselves. On the right here, you can see that different things. Just to mention a few, this is the social media page from Gavi. Down here with the CT scan is the page of the European Respiratory Society. This is Ministry of Health. It is also there. This is WHO. They have a Facebook page where the director of WHO is always updating. This is MedRev, the preprint, the famous preprint, with so many articles coming in. And all you need is to subscribe to them and they will send you everything. And quite recently, I also had to activate my Twitter account and try to share information there. So that is another way of dissemination. And probably lastly, I will talk about the print media and broadcast media. This is also not traditional, as we knew that stories in this media are always not reliable. However, people are continuing to use them. Looking at, to zoom in a bit more on Twitter, our colleagues at the IDI have conducted a study and they have shared with me these slides. As you can see, they have tracked the Twitter activity about COVID in Uganda. This is before the outbreak, this is during the outbreak, and this is how the activity has been. But most importantly, you can pick something. This is during the lockdown in the first months
of the epidemic. The key things which were wash hands, confirmed COVID, test negative. But again, when you see during the open phase, other words start to appear, like COVID death. So by analyzing these two Twitter or Facebook hits, you can actually track what is happening in the community and use that for public health. And this is the print media, which I was talking about. You can see this is in Italy. This is how their print and broadcast media was responding to the epidemic. You can see there were briefs, opinions, and news. This was the rate. But the most important thing here is that the most represented people were actually politicians giving this information, which means that I think as scientists, we need to step into this space and provide the right information. And with this in background, when we started getting our first COVID results, we organized press conferences to release these results where we summarize what the study has found and we provide this to the media. And we have had 2 of those press conferences, and they have ended up making sure that the information is available in the correct form to the general public. I want to thank you very much for giving me this opportunity to present on this topic. Thank you.
Thank you, Bruce, for that summary of dissemination of findings. Quite interesting, especially the new ways, social media, print media, and all the things, and how they are taking the lead in informing society of what is going on, at least for COVID. At this time, as a general announcement, please, if you have questions, 2 options. You either put it in the Q&A, that is Q&A section, or you raise your hand, and I'm going to hand over to Julian, who is going to help us moderate the Q&A question. Over to you, Julian. Thank you.
Thank you very much indeed, and thank you both to Joe and Bruce for some extraordinarily interesting presentations there. As Bernard said, please do let us know via the Q&A or by raising your hand if you would like personal questions. We have got some time. We would very much like to hear for you. But until that happens, I wonder if I may ask both of our panelists a question. I mean, in a sense, both, I mean, Joe talked about silos in relation to the gathering of information and the importance of trying to connect these kinds of silos. And Bruce talked about, in a sense, kind of silos of dissemination, that some things came out via social media, some things came out. There was a general sense that there wasn't a joined up sense of communicating the results of the research. And he also, and Bruce also clearly emphasized the vital importance of communicating results, communicating information in terms of managing the way populations respond. I wonder if I could ask both, and I'll start with Joe, what do you see as the downsides of the risks, as it were, of joining up these silos? Joe, for example, I'm sure there, you know, I'm very much aware of concerns about data security, about appropriation of data by Western pharmaceutical companies. I wondered, Joe, if I could ask you first whether you have any thoughts about the hazards of stepping out of a kind of silo mentality for the gathering of data and samples.
Right, thank you very much for the question. So it has become very clear that as the collaboration among countries and among institutions is supposed to bring a really great sense of what the general picture is, this also brings clearly the inequalities in the capacities and capabilities of the various sites. Take, for instance, if a country that has not very good statistical services or knowledge joins up with another country, then you have the advantage of having the other country being able to bring the resources on board, but also the fear of that country being able to move ahead with your data, publish, even give out that data to a third party, with or without your knowledge, and having this being used. A classical example is the story about Sagisphere, in which we have a personal experience where African Federation at some point used that to develop protocols, only to find out that, well, since we hadn't collected our own data and we decided to collaborate, we were part of the whole issue that had been created. So as much as there are advantages, there are a lot of disadvantages, and there have to be middlemen that would stand and be safeguards to ensure that the data is not being misappropriately used, or the collaboration is being respected on both sides, and each person gets the full benefit, with the overall benefit of knowing that this is supposed to improve patients' care and improve public health resilience for the current emergency and the next one to come.
No, terrific. Because one of the things that I've become, and colleagues of mine become very concerned about during the research that went into the Nuffield Council's project was this radical inequality. This sense that, for example, just, you know, we're talking about, and I'll come on to Bruce in a moment, but questions about dissemination of journal articles. It became clear that actually some Western academic institutions were able to turn these publications around incredibly quickly, and there didn't seem to be enough acknowledgement of people, you know, working in the midst of the outbreaks, and academic institutions in the, you know, in the countries where the outbreaks were taking place. And there was a sense of radical injustice there that I think that, you know, a sense that value was flowing the wrong way, if you like. Bruce, I wonder if you may have any comments on that from a kind of publication dissemination perspective.
Yes, thank you. I think that is one of the other disadvantages of the approach to publication that we have seen coming out, that the different groups and the contributors may not be properly acknowledged. One, because of the speed at which the work is being done, but also the perceived benefit from these publications. If you are writing about a fatal disease like we are dealing with, many people would really want to maximize the benefit, not people, even institutions. So probably that crept in and caused some problems. This is not only for the science, but also for interventions. You've seen the story of the vaccine. Before even I think the manuscript is written, these vaccines, they're all over the internet, and you wonder if this is correct. In one of them, in one day, the effectiveness changed from 70 to 90, and all this information is being consumed. So these are all the disadvantages that we are seeing, but probably the advantages of letting out the information could outweigh the disadvantages, but that's a debate we can have.
Thanks very much. I mean, Charles Lwanga, you have your hand raised. Was that from the last session, or would you like to say something, ask a question now, and you please go ahead.
Sorry, I'm sorry, that was in the last session.
Okay, Charles, thank you very much. Any other questions? If not, there is quite a lot that I would like to ask Joe and Bruce, I have to say, but I really do not want to hog this question. Hello, okay, so could Tobogo, you have a question for the panelists. As I said before, if there's a particular, if you'd particularly like either Joe or Bruce to answer the question, please could you address it to them individually? Otherwise, we can ask them both their thoughts. So Tobogo, please go ahead.
Thank you very much to both the presenters. It's Debo Hoyer from Johannesburg, South Africa. A question that I have is, what exactly is the root cause of these silos of research and information? What exactly is the root cause, and what is the best way to deal with such? Because from what I'm hearing and from what Julian was saying, is it seems like this whole issue of inequality is much bigger than the actual researches that we have, and it is affecting them. So as academics and researchers, how can we deal with these things? And one can also borrow from this from the social sciences, the issue of decolonization. How is that affecting sciences? Thank you.
I beg your pardon, some very searching questions there from Tobago. I mean, two principally, one of which I think is what are the causes of the silo, the fact that that so much information is kept in silos? What are the underlying causes of that? So the second question is about justice and fairness and has to do with questions about decolonizing this kind of response to epidemic outbreaks, set within historical power structures, and as I mentioned earlier, concerns about perverse flows of value away from resource-poor countries towards Western countries. I'll ask, if I may, Joe to go first. As I say, interesting and searching questions. Joe, could I ask you for your thoughts on these?
All right, thank you very much for this. So I would want to take the root causes of the silos. I think the expression, and I'll put in quotes, it's my data. It's my hospital, it's my patients, it's my data, I'm not giving it to you. And interestingly, this continues on for a long period of time. And what makes it even more interesting is that when that data is kept, that data is never analyzed, never published, it becomes too old to use, and then it goes to another set of my data, and then the cycle keeps repeating. The minute the staff do not see any output of that data, then they have no really inclination to stay within the research premise. So you end up building a disincentive of your staff to be very adhered to helping to get research work done, because you keep the data, you don't have the resources to analyze, to publish, and it doesn't happen. The root cause of this is that people have always thought that they will be sidelined if they partnered with a bigger institution, but I think that it has been of late a common practice, but this easily can be remedied with authorship agreement well before the data is shared, and looking at some agreements which can be signed before the data is given out, data sharing agreements, to include the authors from the sites and to ensure that people are well involved in the design of the study, the write-up of the study, the data collection, and finally, the output of the study. And this can be done across institutions and across countries. The holding on to your data only means that your data can only be generalized for your community, for your country, or for a sub-region. But then if it's collaborated, then your data can be generalized for a bigger state. And this would also happen when there's extra training and people recognize the reasons for collaboration, and knowing that you can write a small paper from your institution, but data share your results and have a collaborative paper being written for a general group. If we are talking about the justice and fairness, it really is a problem because of the vast majority in the disparity in skill, capacity, in training. And the way to remedy this, if you ask me, is improving the training, not just improving the training at the clinical level, improve the training at the research level, and more importantly, improve the training at the publication level. Help build local journals, have local journals be improved to be able to publish high-end papers, so that I would know that if I'm publishing with a Ghana Medical Journal, with an Ethiopian Medical Journal, with a Ugandan Medical Journal, I am sure that it will be a journal that will be read by the people of the country and have that impact there. And then collaborative papers, yes, can aim for very, very high-end journals in the other countries. This will provide the ability to be able to have collaboration in country to produce good articles, and also collaborations across the world, which still can be published in local articles in the African context. Thank you.
Thanks, Joe. Before I come to you, Bruce, just to say that Jane and Tom are still, our 4 earlier panelists are still on the line. And I know they have an enormous amount to contribute to this debate. So after I've spoken, after Bruce has had an opportunity to comment on those issues of what are the causes of the silos and questions of justice and decolonization, if Tom or Jane would like to come in, we'd very much like to hear from you. So Bruce, over to you, if I may.
Okay, I think John has given most of it. I will just say that probably what is seen as injustice stems from the problem of lack of research funding in low-income countries. This research funding gap has been made worse by a disease like COVID-19, which has affected almost all countries. The people who are supposed to help are struggling with their own pandemics. So you find that this inequality is going to become worse. Actually, some time back, I checked on PubMed to see how many publications on COVID-19, on this pandemic, are from Africa. It was less than 1%. And this is a reflection of the amount of research activity that is happening in this part of the world, because the external funding is very, very limited, and local funding is not there. The other issue also is the developing capacity to conduct high-level research. That is still also work in progress in most of our countries. This expertise is usually complemented by collaboration with Western universities. In pandemics of this nature, when this collaboration is not happening, people cannot travel, that might be affecting the research outputs in a way we cannot see right now, but probably reflect in one or 2 years down the road. Now, to comment about the silos, this is something that will need constant engagement. As you know, these silos, they are not only continental, they are not only national, they are actually also institutional and departmental. That's how it goes. Even in our small departments, we have our areas which we want to protect. We must be assured that when we open up, our research programs will not collapse in the open field. And I included a slide, the FAIR guidelines, which try to help researchers to see how they can share the data that they have in a way that keeps their programs safe, but also advances the field they are working in. Thank you.
Thank you very much. Could I ask, Jane, is this something that you would like to comment on, either of these questions? Jane or Tom, if this is something that you feel that you can comment on. Jane, I see you've unmuted, is that right?
Yeah, I mean, I think the 2 panelists have really ably responded to the queries that have been raised regarding this. But I think one addition I could add is that the generation of some of these research questions, and this is where the challenge comes from as African scientists, who is generating these research questions and who is driving the research agenda in some of these situations. I think it's a critical moment that the African institutions proactively contribute to the agenda within the epidemic settings, and also significantly contributing to the generation of these research questions and initiating these research activities beyond just the challenges in funding. I think it's quite key if you play the key part in generating the research questions, and then you're able to negotiate some of these authorship positions more proactively and more aggressively. I think it's a mixture of a number of factors, most of which have been reported by Joe and Bruce, and just to kind of encourage the African scientists to contribute a bit more proactive into setting the agenda and actually playing a big role in leading some of these important and critical research activities.
Thank you very much. Tom, would you like to comment on this?
I for one, I think the presenters have actually covered it all. I've not had maybe one issue. I maybe have missed it. You know, when it comes to the pressures of publications, the pressures when it comes to progress in research institutions, in academic institutions, the pressure of publication also creates a culture of knowledge silos whereby individuals tend to keep to themselves what would have been shared and helped colleagues in faculty at the institution level, but they first want for it to come out in a peer-reviewed journal such that others can now come on board. If at all the process of publication, you involve even others, something I think it would help spread out the capacity for others also to do what exactly you are aiming to do. This is just the knowledge silos that I thought that could also be submitted. Wonderful. Thank you.
Thank sorry, I beg your pardon. Ahmed Sani, I saw you put your hand up, but you may have popped it down again, so I won't insist. There is, however, something that a question that I would like, certainly I'm going to direct it initially at Joe, if I may. But also I think the rest of the panelists may also have views on this. I mean, I would like, in your view, within the context of COVID-19, was there anything different that helped in the setup of a multi-center study? Anything that made the COVID multi-center study easier than previous kind of emergency scenarios, outbreaks, etc.? Any thoughts on it? Was there something about COVID, about the response, the global response to COVID that made things easier, that made things happen more quickly?
Thank you very much for this. So I think it became quite obvious very early in February of the year that this was not restricted to one country. And the minute that became quite obvious, collaboration across countries was easier because, one, the disease was unknown and nobody was sure how the disease will progress in a different race, in a different weather, in a different environment. So this allowed people to collaborate. I don't know if it's because they wanted to protect their own interest or because they thought it was good for us to now collaborate, but this made it easier. Also, COVID-19 was after a pandemic, was after a disease like Ebola. Ebola had set people up to set up laboratories, training centers, already built some level of collaboration, such as I explained, the ISARIC document that was sitting ready to be adopted for COVID-19. All of these were available, so there were already pre-existing structures that people could hinge on. Also, COVID-19 brought up the use of technology a lot and improving communication among countries. So this created a really solid platform for collaborations among the institutions and individuals that formerly would have requested for travel in between institutions, and which would have made it a little expensive for such collaborations to happen. But now these are happening virtually. So COVID-19 seemed to have hit a platform where it was more acceptable for people, for nations to collaborate. And because of its global reach, it propelled people to accept collaborations much easier than before. Thank you.
Thanks, Joe. Fascinating stuff. Bruce, any thoughts on any thoughts on
Julian, let me make a comment. This is Bernard.
Bernard, I beg your pardon.
I've worked with the CCP protocol for Uganda, and I think that the biggest key thing here, other than the things that, sorry about that. The key thing for me is that we have two big consortia that are funded by EU. And one of them actually was to look at being able to rapidly conduct research during epidemics. As we know the nature of epidemics, they are quick, they are rapid, they don't wait for nobody. COVID-19 is here 10 months. Some epidemics don't last even 6 months. We don't know how long COVID-19 will stay with us. So if you're going to do research, you kind of need to be ready before the epidemic comes out. And I think ALERRT did create a platform to which a multinational Africa-wide response in terms of conducting research could be done within a short time because all the partners were already collaborating to the same effect, building capacity, building platforms, personnel, laboratory capacity, and all these. So by the time COVID comes, you already have a platform, you already have people collaborating together for the same effort. And once you find funding and you have a cause, it's easy to move through. And of course, the ESCCR is the same. The fact that you have institutions in East Africa, that are already working together to do research. And while previously we would have to wait for our colleagues from the West to come up with research questions, because we've been working together over the years, it's easy to identify research questions and actually put up a grant to Trust that is quite good, and Wellcome Trust will be happy to fund it. And so this is, I think that kind of collaboration needs to be fostered and encouraged widely, because then, the silos that we're talking about, publications where say somebody comes up with that question from somewhere else and comes down here and you're happy to work with them. But when it comes to publications, the story is different. You've done all the work to collect the data, and the best you'll appear is in acknowledgements. And it's purely because, down here as Africans, maybe we're not working together to be able to attract funds. But if we can work together, then we can attract funds for our own agenda, and then the publications will go. So for me, that platform from ALERRT and ESCCR is such a big thing that has helped this to be taken on quite quickly and also to be implemented in a short time. Thank you.
Thank you, Bernard. Bruce, is there anything you'd like to add on to that?
I can just add on the issue of conducting multi-site studies. In our group, all our sites were in the country. None was international. But one key thing which I think could be critical is to have a systematic approach to building research sites in these hospitals over time. When you come with a project which is a one-off, people cannot see the benefit. I totally agree with Joe that promoting science benefit other than monetary benefit is important. But in one project, people really don't see this transforming into something useful to them when they are full-time clinicians. But if efforts are made to create research centers or units within these big hospitals, epidemics will find when we have a critical mass of people who appreciate the value of conducting research. We had almost the same challenges in the different hospitals we went to. People could not see the value of completing these CRFs. Of course, we tell them, yes, we'll get a publication, but if someone has never published, they probably don't know what that means in real life. So that's the only thing I can add, that this pandemic should teach us to create well-developed research centers as a preparation such that we avoid firefighting when pandemics come and we use people who don't know research and that kind of quick fixes. Over.
Thank you very much indeed, Bruce. We have a question that's just come in, which I will take the liberty of reading out. It's got some acronyms in it, so please forgive my ignorance, but I'm not entirely sure what the acronyms mean. It's a question to you, Joe. So I'm assuming that you will know what the acronyms mean, but I will read it out. It's coming from Frederick Omity, and it says, Joe, what are the challenges faced by research groups in collecting SAE, and what is the turnaround time for DSMB in giving final SAE reports? For my benefit, Joe, if you do know what those acronyms mean, could you possibly spell them out?
All right, thank you very much. To start off with, SAE as serious adverse events.
Oh, gotcha.
And DSME, it's the board that it's supposed to, it's a monitoring board for research. So data monitoring, so the data and safety monitoring board, that's it. Data and safety monitoring boards.
Thanks.
So the question is, I'm sure that the idea behind the question is, if you have a large collaboration, how are you able to monitor the serious adverse effects and get these reports out early? I hope I get that right, if that's what the question meant. The idea is that if you have a collaboration among a lot of institutions and a lot of countries, these are supposed to set up their own internal mechanisms for being able to identify serious adverse events and also being able to report it very quickly to the board and then have the board report back. Usually the board's reporting back to you with a report that can be sent to the ethical committees is not as slow as the other way around, with the institutions reporting these in time. So every institution is supposed to have their own monitoring and safety group or board that would help bring out these SAEs very quickly, write an initial report, submit it, and get a report back. But I'll really be happy if my other panelists could throw more light on this. Thank you.
Thanks, Joe. Bruce, is there anything you'd like to add on that one?
Serious adverse events monitoring can be a challenge, especially in low-income countries where expert physicians to investigate these events is limited. However, clinical trials is about SOPs and training and monitoring. So what is needed is that whichever cadre of staff you have, they are properly trained on the SAEs, the forms you use, how to report them, and then institute regular and periodic monitoring of those people. It may not matter how many sites you have, you can be able to conduct this very well, especially even in resource-limited settings during pandemics. The problem with pandemics, especially contagious disease like COVID-19, there are limitations to patient access by clinical teams. And this is a very big problem for COVID-19 clinical trials. No single person will be able to conduct all the safety monitoring. So you have to depend on the entire team. And commitment of these teams varies from person to person. And that can actually create serious data quality issues, especially when the data concerns safety.
Thank you, Bruce. I've got a question here that I'm going to direct firstly to Jane and then to Tom. And there's a question here which I personally have an interest in this one, so forgive me, but it's from Mukisa Herbert. And the question is, what are the existing ethical guidance and what is its relevance to the epidemic response? So I'd be very interested to hear from Jane and Tom, particularly, given their sort of patient protection and research ethics framework, what their feelings are, their thoughts are regarding the utility of the ethical guidance that is currently available. Jane, could I ask you first?
Maybe just a clarification. If you could repeat the question, ethical guidance for what in particular? Is it qualified or just?
It's not specified completely in the question, Jane, but I think we're really talking about the relevance of research ethics guidance to the current outbreak. What's the utility of that in relation to the current outbreak? Are there obvious gaps or problems?
Okay. I mean, I think the overarching goals of all ethical guidance is to ensure that patient safety and patient rights are promoted, to ensure that whatever
Jane, could you turn off
research
your,
is conducted
video, Jane?
is conducted in the interest. Okay. Can you hear me better now?
Much better, thank you.
Okay, so I'm just to repeat what I was saying. I think the main reason we have ethical guidelines is to ensure that the rights and safety of patients are protected, and to ensure that the research that we do has a significant risk-benefit balance, and to ensure that really the different research groups are doing no harm. So the guidelines really provide us, I should say, the environment within which we should be conducting research within the settings where we work. It basically governs all aspects of the research, what kind of approvals will be needed to undertake the research, the quality or the expertise of the different individuals that are conducting research. They should be able to have the right expertise to do what they say they're going to do, but to also be able to track and monitor and ensure that there is no harm. So essentially, it's really the guidance are supposed to track and direct the different research groups to ensure that the rights and safety of participants are really observed and kept through it all. And of course, also to ensure that the benefits of this research may be able to feed back into better management, to feed back into better quality of care, and not just have research groups that come and take and go out to ensure, I mean, within the context that the people who are contributing to the research actually benefit from the research activities. So overall, protecting the rights and the safety of the research participants that are involved in the research that is being done.
Thank you very much. Tom, any thoughts from you on the utility of the available ethics guidance, whether it's in country or whether it's kind of WHO guidance or SIOM's guidance? Any thoughts there?
Actually, Dr. Jane has responded to that quite well, the ideas that I had. When it comes to guidelines needed when it comes to epidemic situations, is the protection, the rights of the researched and also the frontline workers. Now, epidemics come in different forms, and it should be up to the regulatory authorities to improve on what is current in order to guide whatever research is ongoing, in order to ensure the safety of all involved. That's why in my presentation, I mentioned that when it comes to ethical review, we have the national guidelines. All countries should, I think, have national guidelines that they do follow, national and international. But there are some addendums that cause documentation of a risk management plan. All these are in addition to what is already in existence, but the national regulatory authorities can come up and make it better. So these guidelines, not only once they are discussed and approved, would cover the safety of all involved, would cover ensuring that the knowledge that is generated is shared in a time manner so that there will be improvement in case management and epidemic management. And yeah, the utility, the existing safety are the rights. Addendums, you improve on the current in order to make it better.
Thank you very much indeed, Tom. I'm conscious of time. We have 15 minutes and we're stopping on the hour. I'm sure everybody has things they want to get along to, but I kind of want to bring in a question from an earlier session from Mulai about civil society groups and community engagement. A question for Joe, if I may. In terms of the CCP study, what kinds of activities did you undertake to engage the local community in that study, and how effective did you think they were?
All right, thank you very much. Sorry, you might hear some sound behind me. There's a little construction happening, so sorry about that. So it's very important for us to look at getting the community really involved in the CCP. This is data that has been collected over a big number of patients, over a big number of institutions. And the last thing we would want is to be able to get the community turning around and saying that the data is being used for something else. So the involvement in large stakeholder engagement, especially with the civil society, is really important for them to understand what this is, what the data is going to be used for, and then their core involvement in this. So initial data that's produced can be discussed with the civil society groups, can be put out through social media to tell people that we started this, we have found this out, we're continuing to collect more data, we will let you know what else we find out. It was really important to ensure that the community and the civil society really understand what is happening and then not respond to allegations and proportions about what could be the data could be used for, but really have them actually champion the study by having them understand it and protect the interest of the study and of research at large. Thank you.
Marvelous. Thank you very much. We've got a couple of hands raised here. Florence, if I could come to you first, and then we'll go to Tobogo. Florence, what's your question for the panel? And as I said, if there's anyone in particular you'd like to respond, do please say. You're still muted, Florence. You may need to unmute yourself. Okay, Florence, I'll come back to you if I may. Tobogo, would you be willing to ask a question now?
Yes, thank you very much. Looking at Joe's last slide on global health
I'm telling you, that's the thing. That's the thing. How you know? You're so busy. Not myself, at least.
Florence, could I just ask you to mute, and I'll come back to you in a second.
Okay.
Julian, you're muted.
Sorry, Tobogo, do please carry on. The technology.
All right, thank you. Looking at Joe's last slide on global health emergencies, research, and improved health care, treatment, and vaccines, I then think that there are links between each and every one of them, and it is not as clear-cut. You know, we've got political issues that are involved there, poor healthcare, poor facilities, and looking back at Professor Lutwama's comment saying people must not be part of research if their basic healthcare needs are not met. So what I'm seeing is that we find health facilities being so poor and the research not benefiting the clinicians on the ground. Then you end up with a situation where research studies are looking so good and there's a lot of activities, but people at the ground end up with poor health care. So there is a disconnection between research and clinical care on the ground. Thank you.
Joe, any thoughts on that from you?
So this has always been a really, really big problem where you have the researchers in a nice air-conditioned building, lots of computers with huge screens, and then you have the clinicians. The thoughts are the research work happens in the hospital using the clinicians, but then eventually the progress or the output of the research just never gets back to the institution. This is something that has to be intentionally made for researchers to actually go back and have the output put into practical terms in the institutions, and have clinicians rather transition to be researchers, and then the other way around. So for instance, in my case, I am a classic example where I work full-time as an emergency physician, but also work as a research fellow in the Research Institute here in Kumasi. And so work that is being done here, for me, I'm looking at it translating to the patient on the ground, to the clinician on the ground. And this should be a core component of every proposal, looking at how to translate the research findings into clinical outputs. And I think all the attendants and panelists here should actually be thinking about making this a core component of your research proposal and putting it in that these are the ways to translate the research findings into clinical outputs. And I think this will make a big difference and have clinicians transition into research work and taking research training to the clinicians on the ground. Thank you.
We really don't have much time now. But there is a really interesting question that has come in from Kelvin Anoka, and what I think I might do is just to ask. The question is about: are there circumstances? And what we're obviously talking about emergency circumstances in which it is permissible, shall we say, to override or to do without the need for institutional review board approval of research protocols, etc. Can we imagine, and I'll ask each member of the panel one at a time, can we imagine a set of circumstances in which we will say the urgency is so overwhelming that we will set to one side IRB approval? So any thoughts? I'll start with you, Tom, if I may.
Yes, epidemics, as we had submitted earlier on, they come in different forms and intensity. Even if the situation whereby clinical management, case management, hand in hand with research is deployed out there to the communities, there is still a need for a retrospective aspect of review to ensure that the standards were maintained. There are very few instances whereby, you may find that there are instances whereby the epidemic that has come on board requires very quick response. So you may have to notify, at least in our case, you notify the regulatory authorities about what you do intend to do. And they might give you approval to continue, especially following up using standards that experts approve for you to use. And then there could be some retrospective review process when you've already rolled out. But I won't say that there's any interaction with human beings as research subjects, whereby you take it as it is what you determine it as non-research determination. There is some critical element that some people may consider. If at all the primary output is to generate knowledge, generalizable knowledge, then there is a need to review. There's a need for ethical review. If at all, ultimately, is to follow up, say, with an evaluating a program, or evaluating a program, public health, maybe surveillance. That way, you may have institutions, maybe at the Ministry of Health, allowing for such an activity to continue. And if there could be an element of ethical revisiting the activities as if it's an ethical review retrospectively, because you have to maintain the standards. I submit.
Wonderful, thank you very much. Joe, your very rapid thoughts, if I may, on that, and then I think we'll last few words from the panelists, and we'll pass back to Bernard. Joe.
I couldn't agree more with everything that Tom said. I don't think there's anywhere we should be looking at allowing any research without having it reviewed. If it's such an emergency, I think the Ethical Review Board should be able to convene and quickly look at, even if it's a summary of the protocol, give you a conditional approval and have some time to quickly review the rest and advise you on the go. Because the whole advantage of this is to protect the subjects. And if this is being done when you have already committed something that has put a subject in harm, then the point of having the ethical review doesn't really hold anymore. So as much as there's an emergency, these should be put into the structures of building an ethical review committee for them to understand that in an emergency, you will be called on board to quickly review a protocol and advise on the protocol before this is continued. But there shouldn't be any instance where it should not be done. Also, we should also remember that there's a clear difference between when the activities are happening and the data is being collected, and this fine line between secondary data, which is data collected by the clinicians and you using that data. And such data can easily be used retrospectively. So the clinical work can go on and the data can be collected a few days after the ethics has been able to review this. But I do agree that ethics should review every policy and no emergency should outweigh the security of the participants at all.
Thank you very much, Joe. I'm very conscious of time. I want to say thank you personally for a fascinating workshop. All the sessions, all the panelists and speakers, I've learned a huge amount and great responses from our attendees. I'm now going to, so thank you very much from me, and I'm now going to pass you back to Bernard to say our final goodbyes.
Thank you, Julian. Thank you, the panelists. Thank you for the TGHN team and the background. Thank you, the attendees, for a wonderful webinar. It's been great, lots of information, great interactions. Thank you, everyone, for keeping this active for the past, I don't know, since 10 o'clock. That sounds like it's 6 hours plus. Thank you very much. I want to draw your attention to the web chat, the chat. Please, the feedback. Give us feedback and let's know how it has gone, how we can improve the next one. But also you give feedback, then you qualify for a certificate, which will come back to you via email within a month. Thank you very much. I also would like to highlight the TGHN website on COVID-19. Has lots of resources that I think the team can also put that up. It will be very, very helpful for those that intend to do research around COVID-19, but also if you're doing COVID-19 research, you can find there loads of resources and groups that are working. Thank you very much. Until next time, let's say goodbye.